So we move now for the Sintra-Rev clinical trial presented by Felix Lopez. And Felix will be here for the question after.
Good afternoon, you all. My name is Felix Lopez Cadenas, and together with Dr. Adiel Campello, I work on Sintra-Rev clinical trial. First of all, I would like to apologize for not being able to attend the meeting personally, but with this presentation, I will try to summarize the more relevant points related to Sintra-Rev clinical trial, which, as you all know, is an international study on del 5q MDS in which 3 European countries have participated: Spain, Germany, and France. As a background, as you know, treatment of cytopenias remains the main therapeutic goal in the low-risk MDS patients, where anemia is the protagonist cytopenia, which is particularly evident in the context of del 5q MDS setting. Thus, the vast majority of patients present with symptomatic anemia at the time of diagnosis, and even more than 40% require transfusion support at this time. In addition, the probability and duration of response to EPO in this MDS subtype is lower compared with other low-risk MDS. This makes it particularly difficult to treat these patients before the development of transfusion dependence, which moreover occurs soon after diagnosis, after a median of only 1.7 years, according to a retrospective study of the Spanish MDS group. Treatment with lenalidomide at a dose of 10 milligrams per day in the context of established transfusion dependence demonstrated in a large phase 2 and 3 trials relevant rates of transfusion independence and cytogenetic responses, and moreover showed an improvement in terms of quality of life, overall survival, and transformation to AML who achieve a relevant response among patients who achieve a relevant response. But despite its well-known efficacy and safety profile in this group of patients, no randomized clinical trials have been conducted until now, exploring the real advantages of advancing the use of lenalidomide to the pre-transfusional setting. So, in an attempt to answer the question of whether initiating low-dose lenalidomide before the development of transfusion dependence provides any benefit in terms of a longer time to transfusion dependency and other outcomes, we designed this study. Regarding trial design, Sintra-Rev is a phase 3 double-blind placebo-controlled clinical trial in which low-risk del 5q MDS patients with symptomatic anemia but without transfusion requirements were included. Patients were randomized 2-to-1 to receive either 5 milligrams of lenalidomide or placebo for 2 years. After the end of the treatment period, patients entered in a long-term follow-up period for 2 additional years in which data on disease progression, including AML, death, and its cause, were collected. Additionally, follow-up after the end of the study was extended to increase the long-term surveillance. The first patient randomized was included in 2010, and we have a long period for recruitment due to the special characteristics of this population with a low frequency. In fact, the last patient was enrolled in 2018. The primary endpoint of this study was to assess whether treatment with lenalidomide prolongs the time to the development of transfusion dependence from the start of the treatment compared to the current standard approach, that is, observation and monitoring the disease. The most relevant secondary endpoints included erythroid and cytogenetic responses, overall survival, event-free survival, and rate of transformation to AML, and safety, including clonal evolution. In this slide, you can find the main patients and disease characteristics of the series, which on the other hand are the typical of this population. The majority of the patients, more than 80%, were female, and median age was 72 years old. About 90% of patients have del 5q as an isolated cytogenetic abnormality, and median hemoglobin level at inclusion was 9.8 grams per deciliter. Median time from diagnosis to the start of the clinical trial was 3 months for the entire population. Both groups were well balanced since no statistical differences were observed between arms. And moving to the results, as you can see in this table, median time on treatment was more than double for patients in Len arm, and near 50% of them completed successfully the treatment as compared to only 33% in placebo arm. The main cause of discontinuation was the development of transfusion requirements that represented 83% in placebo arm as compared to 47% in lenalidomide arm. And what happened with the primary endpoint? So after a median follow-up in the intention to treat population of 5 years, a total of 23 patients, 38%, developed transfusion dependence in the entire cohort. Only 25% of LEN patients became transfusion dependent compared to 65% in placebo group. In addition, lenalidomide reduced the risk of needing blood transfusion by nearly 70%. The median time to transfusion dependency from treatment was significantly longer for patients treated with lenalidomide, which median was not reached, than for those receiving placebo, which was only near 12 months. And moving to the secondary endpoints regarding AML transformation rate, there were not statistical significant differences between both groups. Transformation to AML was observed in 6 patients, the 15%, receiving lenalidomide after a median of 52 months from the start of the treatment. 1/3 of transformed patients in lenalidomide group had a TP53 mutation at diagnosis. And on the other hand, 5 patients, 24% in the placebo arm, were transformed to AML after a median of 55 months, one of whom had a TP53 mutation at diagnosis. And with regard to the event-free survival and considering as even the onset of transfusion dependency, transformation to high-risk MDS, or AML, or death, it was clearly favorable for the lenalidomide group. Thus, the median event-free survival was nearly 7 years for lenalidomide patients compared to only 1.7 years for patients who received placebo. The median overall survival was 8.4 years for the entire cohort, and no statistically significant differences were identified between the 2 treatment arms. And regarding hematological responses, the 70% of patients receiving lenalidomide reached an erythroid response at any point during the treatment, a percentage that rises up to 78% for patients with available hematological response assessment. Similar to the hematological evaluation, a cytogenetic response at any moment during treatment was only achieved by patients within the lenalidomide arm and was observed in 80% of patients receiving lenalidomide, most of whom presented a complete cytogenetic response. It should be noted that in relation to the population with at least one available cytogenetic response assessment, the percentage of patients with a cytogenetic response increased to 94%. And about the safety of the study, as expected, the most relevant toxicity was hematological. In lenalidomide arm, any grade of neutropenia was observed in 63% of patients, with the grade 3 to 4 occurring in nearly 45%. An episode of febrile neutropenia occurred in only one of these patients. Thrombocytopenia was the second most common hematological toxicity, affecting 18% of patients, most of whom had grade 1 to 2 and without any relevant hematological event detected. Regarding the non-hematological toxicity identified as potentially related to the treatment, digestive and skin disorders were the most frequent in LEN patients, and practically all cases were mild. With regard to secondary neoplasms, only 1 patient in the lenalidomide group had a cancer diagnosis while the treatment phase. But during the long-term follow-up, 3 additional cases were identified in the LEN group, all of them more than 3 years after the enrollment, as well as 1 patient in the placebo arm. A total of 19 serious adverse events were reported in 13 patients, 18 in the lenalidomide and 1 in the placebo arm, 5 of which were potentially related to the study drug. One of the main concerns about the early use of lenalidomide was whether it could favor the development of pathological clones, especially driven by TP53. To monitor this, we checked the molecular profile by NGS of most patients at baseline and every 6 months of the treatment and follow-up phase. The most frequent mutated genes in our series was SF3B1 in 25% of patients, followed by TP53 in 21% of patients, both with similar rates in both arms. 36% of patients didn't present any myeloid mutation at diagnosis, while 19% of them had 2 or more. And in terms of the behavior of clonal evolution during treatment, we try to summarize what happened at the molecular level with this figure that you have in the right of the slide. Thus, we observed a gradual increase in the median BAF over the course of treatment in the placebo group, which contrasts with the pattern that in the lenalidomide group, where a significant decrease in clonal size was observed, especially at the 12-month assessment after the start of the treatment. And obviously, we paid special attention to what happened to patients with TP53 mutation. As we mentioned before, 6 patients in LEN arm presented at the inclusion TP53 mutation, and some of them reached erythroid and cytogenetic responses with a median duration of response similar to wild-type patients. We also confirmed that the clonal size of TP53 decreased in the majority of the patients during the trial. 2 out of 6 patients developed AML 60 and 70 months after inclusion, and also we identified in 3 patients the acquisition of TP53 mutation in some of the follow-up evaluations that were not detected at baseline, all of them at subglobal level with a small buff less than 5%. Regarding placebo TP53 mutated patients, we observed that buff remained stable during the treatment and follow-up, and 1 out of 5 developed AML at 15 months after the inclusion. To summarize, the early treatment with lenalidomide at low doses demonstrate that it prolongs the time to and decrease the risk of transfusion dependency. Besides, with this approach, a relevant percentage of erythroid and cytogenetic response was observed, being higher than we usually see in the dependency transfusion setting. Of all of this with an acceptable and known safety profile and without evidence of promotion of clonal evolution, even in patients with TP53 mutation. Because of that, we think that lenalidomide could be a good option to treat anemia, symptomatic anemia in these patients, even before the development of transfusion dependency. So thank you all for your attention, and I will be glad to answer all the questions that you may have regarding Sintra-Rev clinical trial. Good afternoon.
Hello, you all. I don't know if you can you listen to me?
Chat, Uwe.
Yeah. Can I see Felix or not? Felix, do you hear me? Felix?
I can, yes.
Wonderful. Can you see me? No.
See,
okay.
No, but I can hear you.
Okay, wonderful. Hi.
Hi, how are you?
We are here. So thank you for your nice presentation. Just a couple of questions. Number one, you mentioned the decline of P53 clone in LEN-treated patients, right? Can you give us a little insight on the magnitude of molecular response and what was the allelic burden at the very beginning? You know, so was it, did you, because in my experience, actually clone size only goes down if the clone at the beginning is not doesn't have a very high allelic burden. Is that what you observed as well? Or was it really a significant, like 40% VAF to 10%, something like this decline?
Yeah, most of the buff at the beginning of the disease, the TP53 were low, even these patients as well. And what we can see at these patients, especially at the week 12, is like a reduction in almost all the 6 patients, not in one. And finally, only 2 of these patients transformed in acute myeloid leukemia, similar months after the entrance of the treatment than the others. So yes, most of them had a low buff, and of course, none of them had 2 double mutations or another cytogenetic abnormality outside del 5q. But there are so small numbers, only 6 patients in the lenalidomide group and 5 patients in placebo. So I don't know if we can be sure about what we observed only with these patients. But with what we can see, of course, is that the clonal didn't increase with the early use of lenalidomide. That was our first concern about this early use in this context.
Hi, can I ask you another question? I'm Elena Crisa from Italy. Do you have already any data on the follow-up phase when you stop lenalidomide? Patients are still in response. What happened?
Yes, 13 patients, I think, finished the study protocol like normally with the 2 years of follow-up. I think none of them transformed into the transfusional setting, but some of them started lenalidomide like offshore, not in the indication. So we have not the numbers to be sure about this, but we are trying to analyze, of course, this little amount of patients that after the treatment phase stopped the treatment with lenalidomide, because, as you all know, is not what we should do in the normal out-clinic patients activity.
Thank you, Felix. There is no more question. So I think now we can move to the next presentation. So it will be Raphael. Yeah. So Raphael Itzigson for the CMML clinical trials. Thank you, Raphael.
Thank you, Thomas. Great to see everyone here. I'm really sorry because I will not be discussing, I think, any like unpublished data. So I guess the story is well known. So hopefully there's going to be a discussion as to what should be the next steps in the CMML space. So this is where I start la siguiente. We're going to try different languages. So I think we can switch to the next one. The last speaker of the day will have a tougher job. Okay, can we switch to the next one? Okay, so I'll mostly discuss the past, briefly allude to the present, and hopefully you guys tell us what the future should be. Next slide. I used to have like super dynamic slide sets, so this is going to be a pain. Anyways. So mostly the idea today, I guess, is to discuss again the disappointing results of the randomized Dakota trial that we did together as a first EMSCO clinical trials. That was Uwe, Valeria, and Pierre at the initiation of the study, where the idea was to randomize the cytopine conventional regimen versus hydroxyurea as we are used to do it. So it means we had to sort of codify the way physicians would administer hydroxyurea in this trial. Whether we succeeded in that way, I don't know. And there were two surprising things that are, I think, definitely part of the past in that trial. That was the study population, and that was the endpoint. So two minor aspects of the trial design. So the study population is myeloproliferative CMML, with the conventional cutoff of 13 gigs per liter. And we're currently doing a detailed statistical analysis of the Dakota trial, suggesting that this sort of historical cutoff for white blood cell count in CMML is actually an optimal clinical cutoff, which is reassuring. And criteria for advanced disease. And these were mostly criteria that had been used in previous GFM trials focusing on CMML, and that were independent from the more recently developed prognostic factors. And the endpoint was event-free survival rather than AML-free or overall survivals. Not so much because we were concerned about the study metrics and number of patients we would need to accrue to have a meaningful impact on overall survival, because this was what we were aiming at, but we were so intimately convinced that the decitabine arm would be superior that we felt it would be unethical for patients randomized to the Hydrea arm to remain on Hydrea until such an event as a death. So next slide. So these are the key eligibility criteria. These were patients not eligible for allogeneic stem cell transplantation. And obviously, as the accrual period extended, it means that we enriched for patients that were older and frailer, because there is still the strong conception that allogeneic stem cell transplantation is, quote unquote, the only curative option in CMML, if there's any. And so that was the first thing that we have to bear in mind. The second one was this definition for advanced disease that is a mixture of myeloproliferative and cytogenetic abnormalities and cytopenias. Obviously previously untreated, and otherwise it's pretty standard. Next slide. Okay, so this was the study rationale. This was the 2-year overall survival from the 2 previous GFM trials exactly in that patient population. Around 20% 2-year survival in the historical IDRIA data, and around 50% in the decitabine. So it was a no. It was not a game. Next slide. Again, these are the definitions of events that we had in the trial: death, transformation to AML, and progression, including doubling of bone marrow blasts with worsening of cytopenia. So I would say myelodysplastic progression, there is no question about that, and a very clear increase in white blood cell count or newly diagnosed extramedullary disease after at least 3 cycles of treatment for, let's say, myeloproliferative progression. Next slide. So this is the study population. Again, sorry, there's a slide animation here, so we should go with the next one. It's quite frustrating, and this is mixed up. So you see patients were older than 70 on average. Only 1/3 had actually more than 10% blasts. Less than a quarter had severe anemia, and many of them had received previous hydroxyurea. So really a super proliferative patient population. Median white blood cell count with 30 gigs per liter. It was closer to 20 gigs per liter in previous historical trials. So old, potentially frail, and super proliferative. This is the Dakota patient population. So a super high risk population. Next slide. This is the footprint from a genetic standpoint, and make it clear that we found absolutely no evidence of genetic interaction in terms of response or survival and treatment arm in that trial. Okay, next slide. So we have, at the time of publication, and there has been no update until then, we had 17-month median follow-up. This was 10-month only in the IDRIA arm, in the IDRIA historical data set. So we had longer follow-up. And this is the event-free survival, totally superposable between the 2 arms. And next slide, it's going to be the overall survival, which you know is also pretty comparable. And I must say that I will show that on the next slide. The long-term outcomes of that trial were a bit surprising to us, but if we look just at median overall survivals, these were the median overall survivals from the 2 previously published trials. It was exactly 20-month in the Wattel study, and it was exactly 18-month in the Tostenbaum study of decitabine. So we reproduced the same short-term survival effects of each drug. What differs compared to historical data is the long-term survival, which is disappointing in the decitabine arm. Next slide. Okay, there was no impact of censoring at HMA onset, neither at allogeneic stem cell transplantation, but this is fewer patients. And next slide. No evidence for heterogeneity. We looked at blasts, platelet counts, anemia, CPSS molecular version, GFM score. So no evidence that there's a specific subset of patients that preferentially benefited from one option versus the other. Next slide. Nevertheless, there was a difference in terms of response pattern. It was modest, but it was detectable. In terms of CR, we are in the lower range of complete remission with single agent hypomethylating agents. and it's probably the true figure. So 12% in the decitabine arm. Nevertheless, there was a significant number of patients that obviously achieved myeloproliferative control with hydroxyurea. Next slide. This, to the best of our knowledge, remains the most convincing, or maybe I should say the less unconvincing explanation of why there was no difference in terms of overall survival in that trial. So there was a benefit in terms of cumulative incidence of progression or transformation in the decitabine arm, but that was counterbalanced by higher non-progression related mortality. So this could be true, means decitabine is too toxic in that patient population, or this could be false because the definition of progression is loose, and actually those patients did not die in the dotted curves. They did not die because of toxicity. They just died of CMML that was not captured by our definition of progression or transformation. So in order to understand this better, Sylvie Chevret, who is the lead statistician on the study, under, I think, Uwe's impetus and mine and Valeria's, is currently inspecting the outcome of patients by breaking them cycle by cycle. And there is some preliminary indication that this toxicity hypothesis may hold true. And I hope at some point to provide you with a dense and hard to understand stats report that generates a hypothesis as to why Dakota failed and why HMAs may still be a good backbone for future CMML trials. And we all say, phew, because we are all doing that for our trials right now. Okay, so next slide. Okay, so this was the observed survival in our patient population. We reproduced the results of decitabine, but the outcome of our patients treated with hydroxyurea in that trial, even though they were older and more proliferative than those in the Wattel trial, the outcome was better. So a very simple explanation is there are 3 decades between those trials and supportive care is much better. I am uncautiously optimistic, and at present, I cannot find any alternative explanation then. Just to improve the supportive care of these patients, and we have improved their outcome. Okay, so next slide. So we do still have correlative biomarkers studies ongoing. If our underlying assumption remains that like decitabine is a great treatment for a fraction of CMML patients, not sure I believe in that option, but we're still exploring that. Actually, Ken Figueroa, as you know, is doing that with methylation markers. I definitely need that we can translate this higher response rate of HMAs into meaningful survival benefit by factoring for the frailty of those patients and improving the safety profile of single agent HMAs in this super high risk patient population. And again, this is what we're working hard with Sylvie Chevret at present. This reminds us that even though these patients are not neutropenic, they are still prone to infections, and this was the main cause of non-progression related death in the trial. Okay, the rest are usual, praises for more targets and preclinical models, etc., which are irrelevant to today's discussion. Next slide. So that was the past. This is the present. You see there's a barred line, which is this summer's disappointment to everyone, the disappointing results with magrolimab in MDS that actually prematurely ended the project to investigate that agent combined with azacitidine in CMML. We are currently doing a phase 2 trial of azacitidine venetoclax in this patient population. So it's funny to see that obviously there have been a couple of retrospective single center reports for that combination, which is the obvious go-to in myeloid neoplasms. People are very, have strong feelings about the results of that trial. Let's see if those feelings translate into figures. And as you know, many of you are going to participate in the trial that was initiated in Germany, but to my understanding is going to accrue patients at the European level, which is azavan plus tagrazofusp. And there's an exceeding R in the tagrazofusp name, which is complicated enough. Next slide. And the cool thing is, next slide. La siguiente. Diapositive suivante, s'il vous plaît. Okay, the guy is French speaking. Okay. So these are non-randomized phase 2 trials. But remember, we had exactly the same survival in the Dakota trial regarding the decitabine arm with almost 90 patients as we had in the 30 plus patients treated in the phase 2 trials. So I think, and I mean, I'm very surprised that I'm saying that, but I think non-randomized trials are decent in CMML and should still be considered. And the cool thing is that even though we have slightly definition of CMML because our trial is based on WHO 2016, not 2022, but otherwise we decided to focus on the same patient population, those that are higher risk according to CPSS. And I believe that these eligibility criteria will wipe out the difference in patients that are potentially going to be screened in both trials. We'll end up with quite similar patient populations. So we are doing our sort of, European randomization, which is, I think, a cool way to go. And we have chosen the same response criteria, the same primary endpoint. Okay, la suivante. You may have heard of this this trial that has been discussed for, I think, quite some time. That is dedicated to CMML patients, but also to other MDS-MPN patients, the so-called abnormal marrow 001 trial. You see many flags on that slide, probably more slides than patients accrued in Europe at present, but anyways. This is going to be a phase 1b trial of Aztec-727 plus a JAK inhibitor, itacitinib, and this is our first steps into really running international trials in CMML, which is obviously pretty exciting, but also pretty complicated. Next slide. And so as we are discussing what our future steps are, I don't know for the PATROL study, but I should emphasize, and this is, I think, an important change from Dakota to Avenir, is that Avenir, the trial azavan, is aimed at patients that are also eligible for allogeneic stem cell transplantations, and we expect those patients to actually be enriched in the trial. Obviously, again, more than 10 years have occurred between the design of the Dakota and the Avenir trial, so transplant eligibility has relaxed in terms of definition in that patient population. But I think we should remember that very basic assumptions in CMML should also be challenged and may merit dedicated trials at the European level, such as the role and timing of allogeneic stem cell transplantation. Marie Robin and many of us in this room have discussed a lot with statisticians from EBMT to try to do our best with retrospective data of patients transplanted or not in CMML. And the bottom line message of that published paper, again, this is all published data, is that it's pretty easy to see which patients should never be transplanted, those who are lower risk. It's harder to identify a subgroup of patients that clearly benefit from upfront stem cell transplantation, just because the TRM and the relapse rate of the procedure at present, at least in our experience, is still very high. So that leaves us with many questions, which is both exciting and daunting. La suivante, s'il vous plaît. How and where to perform allogeneic stem cell transplantation? And again, I think there is room for clinical trials, I think we should discuss with our EBMT colleagues what we can do there. There are going to be EBMT guidelines, but those guidelines are going to be based on whatever evidence we have, which is low at present. Are hypomethylating agents the best backbone? I think the good thing with Dakota is that it allows us to be much more flexible into whatever trials we want to design for CMML. I think for our colleagues from the regulatory agencies, it actually adds a layer of confusion as to how a drug should be registered in the CMML space. Hopefully there are going to be some, not guidelines, but some thoughts that are going to be published here. And I think the FDA notably is open to many suggestions from us here. I tend to think that HMAs are still the best backbone, but probably with better management and probably for a limited number of cycles, now that we have less sort of toxic HMAs that are orally administered. Is cytoreduction disease modifying? This is also something that we're going to explore in CMML. And finally, we've discussed a lot of trials focusing on the high-risk patient populations, but there are also patients that have lower risk CMML, and even those patients with so-called lower risk CMML transform little, but they do have a lot of, they have increased mortality. And obviously these patients are also patients that have, clonal hematopoiesis clones and have been carrying them for ages. So I think we should also investigate causes of death in this patient population and find innovative ways to intercept their disease evolution. And I think probably the most important slide here is la suivante. Is the acknowledgement slide, because it's going to be hard to find someone in this attendance that has not contributed to those studies. La suivante, s'il vous plaît. So again, a warm thank to to all our colleagues from FISM, from the Dutch, the German MDS group, EBMT, and obviously GFM, both the staff and the central biology, central labs, and obviously all the clinicians. Still way to go.
So, thank you, Raphael. I know your answer, but do you think, because the pharma is here, do you think we no?
I think we should include those patients in the drug labels, not necessarily the drug. Okay, joke aside, I mean, okay, the soft answer is excluding those from MDS trial is a blessing in disguise, because it allows for the potential to do CMML specific trials. I think now that there is attention on CMML, I think there is momentum. I think the companies that me or other people, the companies that have been approached who have an asset that is, somewhat relevant to CMML, they've never said no. Okay, and we know that the study metrics to demonstrate something are not that huge. We've demonstrated our ability to conduct trials together. So I think it makes sense to exclude them from MDS trials as long as we are able to do CMML specific trials. Anyways, if I was saying the opposite, then Lionel would counteract me immediately saying, do not accrue those in MDS trials.
It's a sort of provocative question. So current classification, I mean, those from the past year, highlights the fact that some disease we consider as MDS are in fact through CMML or maybe becoming CMML. So is there some room or some possibilities to have some preemptive treatment or some thought about that?
Yeah, I do agree with you. That's what I alluded to by saying that we should intercept lower risk CMML, and that extends to obviously those oligomonocytic CMML. I think like in French, to speak like a French philosopher, I would say de quoi la LMMC est-elle le nom? So what's hiding behind the name of CMML? So what is really specific of CMML? Is it like a specific, monocytic population or immature granulocytic population? And we should, just classify whatever myeloid malignancy is with or without this aberrant monocyte or granulocyte populations. But okay, leaving those, let's say, philosophical considerations apart, I think we do have challenges designing lower risk CMML trials, again, because the clinical issues with those patients is heterogeneous. Some have mild myeloproliferation, others have mild cytopenias. I think a response is not going to tell us a lot from a hematological standpoint. So my present interest, but we're strongly lacking the data to investigate that, is to look at a broadened definition of event-free survival, considering many events that are not hematological per se, but could be favored by the CMML biology, the TET2 clone, whatever, and that goes way beyond, AML.
Should I? Yeah, okay. Number one, I would like to congratulate again the French group for leading such a great study. I think the concept of the study was born not in this room, but was born in this community. I think I would say 8 years ago, something like that. And I think you took leadership, and it's after the, I will not pronounce it right, Dr. Wattel. I met him once, but I think it's a landmark paper, the JCO paper, and I think we can be proud. I just want to say we can be proud that we, as a group, as a European group, produce this data. Although they are negative, but I think your presentation still presenting negative data, was very fascinating. Just to be no, honestly, you made it. I mean, I have never attended a presentation presenting negative data which was so fascinating. So no, it's true.
How many negative studies have I found?
Right? Okay. So and now comes the idea. What about RAS inhibition? RAS. What do you say in French again? No. Okay. Good.
So as a joke, when I did my thesis, my medical thesis, it was like an AML study comparing different post-remission therapies, and I ran, like 200 log-rank tests, and all of them were non-significant. Which, if you consider an alpha, risk of 5%, is just difficult to believe. So yeah, probably I should, step aside. Okay.
Lung cancer and other diseases, there are now, there are now. Repeat.
Yeah. So question
okay.
is about RAS inhibitors.
Yes.
So these come in 3 tiers. Obviously, there's the already available KRAS G12C inhibitors. This is 0.0001% of our patients. So okay, leave those. Then there's the just recently published pan KRAS inhibitor that we should follow up very carefully. But I think closer to our intentions are inspired by melanoma biology. There are pan-RAF inhibitors with some studies combining pan-RAF and MEK inhibitors that have shown some activity in NRAS mutated melanomas. And I think we should, investigate that. Whether the RAS pathways of vulnerability in virtually all CMML is still an open question. I had my preconception, but it's from my PhD year, so that's 10-year-olds. But I do think that this pathway may not be the cause for myeloproliferation in 100% of CMMLs. I think we have a group that has this pathway activated and another group that is closer to a typical CMML, with ESXL1, ZBP1 related myeloproliferation that is probably independent from the pathway. So, and that I think we can already investigate, and this is feasible. And I urge you translational guys to do that so that when we have those inhibitors, we know which patients to accrue so that some guys do not come here in 10 years showing negative data with those agents.
So thank you, Raphael. So we will move to the next presentation about lower risk MDS with thrombocytopenia by Elisa Crisa. Elena.
Sure. So good afternoon to everybody. I'm Elena Crisa from Candiolo, is near Turin, Italy. And I'm presenting these 2 days on behalf of Professor Valeria Santini that unfortunately couldn't be there. So first slide, not even next one. So my presentation is on lower risk MDS with predominant thrombocytopenia. Next. And so we know that it's quite an issue, even if most of our patients are anemic, still quite a few are also thrombocytopenic, particularly higher risk patients, but also lower risk one. And in this setting, we do have major bleeding and we can have fatal bleeding. So it's something we should take in account. Next. And we know that platelets count affect survival. This is a study showing that the platelets below 100 or 50,000 can impact on survival at diagnosis in both higher and lower risk disease. Next. But we don't have many treatment options for now. And we also know that even if we split patients in higher or lower risk MDS, and we still find thrombocytopenia in both groups, also we have to take in account that thrombocytopenia is itself a factor in the model and so affect the model itself. Next one. But what we have to treat thrombocytopenia. So I won't show you really new data. I will show you what we have and what we have recently published with the QUAL-1 study and what we have designed as a retrospective study within FISIM. So we have transfusion and we have thrombopoietin mimetics. So we know that these drugs act on thrombocytopoiesis, but also they stimulate stem cell. And we don't have any of them approved in MDS. We have a few molecules approved in ITP, romiplostim, L-thrombopag, and now avatrombopag, and in aplastic anemia, L-thrombopag. And from trials that I think you all design and participate in, we know that romiplostim can lead to 40% of platelet response in MDS patients. And we still don't know what is the effect on the natural biology of MDS, because we know that we have safe messages from romiplostim trial, and I will show you from the L-thrombopag trial that it doesn't seem like to increase the ML progression, but still we have transient and relatively short-term effects on the platelet levels. And also we don't know if these effects will be sustainable in the long term and after suspending the drugs. Actually, we know that if we suspend the drug, for now, the platelets will drop. Next. And the concerns that we have now are on the increased blast in peripheral blood, even if, again, we didn't see many ml. I do still see increasing blast in peripheral blood during treatment with these TPO mimetics. And also the potential for myelofibrosis, which is something I would like to discuss all together because, again, sometimes the thrombocytopenia goes with fibrosis. And so we have patients starting with MDS with fibrosis, also a new entity according to the new classification. And also we have the problem of platelets fall after drug suspension costs. And next. I do think with this caveat that we should consider TPO mimetics in patients with thrombocytopenia refractory to transfusion. or to antifibrinolytics, and when the platelets count is below 30,000%. Next. But I want to also discuss with you if looking at also the recent data that I will present on the L-thrombopag use, we think that we're ready to use these drugs outside clinical trials. Of course, taking account the lack of a label, but also if we feel confident in the safety and of these drugs. Next. So I'm briefly going to show you the results that have been recently published in JCO of this QOL-1 study that we did in Italy, but also some of you participated, or many of you. And it was a phase 1, phase 2 trial to determine the efficacy and safety of L-thrombopag in MDS with low or intermediate 1 risk with platelets count below 30,000 that were ineligible to other treatments, and which had adequate, of course, baseline organ function. The phase 1 study proved the safety, and I will show you next the phase 2 results. Next slide. So this was the design. There was a random 2-to-1 L-thrombopag versus placebo. After the phase 1, patients in response could continue in the phase 2 part of the trial. The starting dose was 50 milligrams, and it was allowed an increase up to 300 milligrams per day. Next. These were the study endpoints. The primary endpoint was duration of platelet response, long-term safety and tolerability. And among the secondary ones, there were, of course, overall survival, leukemia-free survival, and incidence of and severity of bleeding. Next. So these are the response rate. You can see that as in the romiplostin trial here, we saw 42% of platelet response in a thrombopag arm. And the median platelet count was higher in the L-thrombopag arm again. And there were 54% of transfusion-dependent patients that become independent. And this is the curve of the cumulative proportion of response that was quite high and also quite rapid, quick. Next time, sorry, next slide. And again, you can see that we have a response in 2 weeks in the L-thrombopag arm. That is quite important when we have patients with high transfusion burden, then have to come to clinic every other day. And the median dose that actually led to the response was 50 milligrams. So from this study, we learned that we don't need to go up to 300, and maybe the range of the also aplastic anemia can be the one that we can use. Next one. One interesting result is that the response, the platelet response was associated with the hemoglobin level, maybe because of the trilineage stimulation of the L-thrombopag. So when the hemoglobin started raising, also we observed the platelet response. Next. And the duration of response. So even if the patients on treatment, the median follow-up of patients on treatment was 6 months, still we had patients being on treatment for up to 5 years. And you can see that the response is quite sustained. If we take in consideration only the responding patients, there were only a 25% losing the response. So this is quite promising. Next slide. The bleeding were higher in the placebo arm as expected. Next one. Next, thank you. And the adverse events were, of course, more in the L-thrombopag arm, but they were not such high to meet the stopping rule of the trial, and basically mainly were liver toxicity, so quite manageable. Next. And finally, going to survival outcome, there was no difference between L-thrombopag and placebo. The median was not reached for both arms. But again, this is reassuring. ML evolution was similar in the 2 arms and was quite low, 17%. So I think we can conclude that I think there are safe drugs, but still these patients has to be monitored more with close eyes on the blast, on the count, and maybe with the repeated marrow, as opposed to patients that are only receiving transfusion or drugs that are not impacting on the stem cell. Next one. And I'm quickly just presented the design of the study that we just started. This is a retrospective observational study based on our registry of the FISIM registry on patients with lower risk MDS and predominant thrombocytopenia. Next slide. So it will be an observational retrospective study, and we will include patients. We are including patients that are at EPSS revised low, very low or intermediate with less than 100,000 platelets at diagnosis, and of course with available data on molecular characterization, biology of disease, and treatment received. Next one. And the objective are to define the role of thrombocytopenia in the clinical evolution of these patients, to evaluate biological elements related to the degree of the thrombocytopenia as the fibrosis, as I mentioned before, and evaluate the impact of treatment, including maybe the new TPO mimetics that are being given to patients in order of label, and identify possible predictive factors of response. And in the endpoints, we will look at progression-free survival, overall survival, time to ML, response to treatment, splitting patients according to the platelets level. And now we have selected from the registry more than 2,000 patients with thrombocytopenia, but only 700 with lower risk disease. And we are completing the data to start the analysis. And with that, I conclude. Thank you for the attention. I hope I was quick.
Microphone, s'il vous plaît. No, it works. Okay, thank you. Sorry.
Just that I don't speak French.
No, number one, congratulations to the great study. Two questions. Number one, you looked for the survival difference, and there was no difference. But what about responders and no responders? Did they achieve a survival difference, like now commonly observed with also luspatercept, also other agents? I mean, it's a rule of thumb that the responders often do better in clinical trials, but maybe you have done this analysis. And number two is quality of life, because you also had like anemic patients, you know, inside, and also in ITP, there's a lot of discussion on fatigue, which is associated with ITP, and nobody knows why. And then if you give TPO receptor mimetics, then the fatigue and the quality of life improves. Again, nobody understands why that is the case, but what happened here in this trial?
So as far as I know from our data, so there was no difference also in the responder survival, probably because the median was not reached. So lower risk patients, so survival maybe was not an outcome that could impact with such low follow-up, because in the end, majority of patients have a median, so the median follow-up is 6 months. Probably with a longer follow-up, this may change. And the other thing is quality of life didn't differ from the two arms. If you look at Thrombopac versus placebo, but differs for responders. So again, we don't know if it is just having less platelets transfusion, coming less to the clinics. We also did a study on quality of life, a questionnaire in Italy, and we saw that the treatment didn't impact quality of life, but access to hospital time, and this may have a major role in how patients feel.
Talkative today, but maybe I like.
I have a question back then
maybe
for you.
I like to be here, and France is my second home, and I don't know. But you know, this is a very clear example of there is a medical need, because patients, tiny amount of patients, but there's a medical need. You recruited this trial, but there's no approval of drugs. So shouldn't we take this as a platform together with patient advocates, you know, and bring this to the attention of the EMA, because you have a randomized trial. We have this EMSCO romiplastin trial. We have the old romiplastin randomized trial. So we have so much data, and bring it to and say, please approve these drugs for us?
I think this was my question for you, because I think we are, so my question in the beginning was, are we ready to use it in everyday clinic? I think we may be ready, and we need to find a way to prescribe the drug. In Italy, we have a law that is 648, it's for like transient approval for drugs that are limited to small patient population, but there's no process now open for thrombopoietin mimetic. So maybe with Europe, we can do it. I don't know what you do. If you can prescribe it off label, you do prescribe it off label, you give it as ITP. I don't know.
What I'm saying is we need to bring it to the EMA, they approve it.
Because they don't have anything else.
Sponsors first, only companies can take drugs to EMA, and you know, some years ago we tried for.
They didn't want to do the registration.
Eventually, one company accepted, and even for example, for ATO, for first time APL, we had to lobby, and because the company did not want, so they were threatened to have other drugs refused if they did not submit, and we lobbied hard, and it eventually worked. And but the second, so there's also EuroBloodNet, so which you are part of, and our purpose is to bring approved drugs to allow them to be reimbursed in various countries with the help of patient support groups. But that's only for approved drugs like interferon in MPN, but this drug is not approved for MDS. That's the yeah, of course, but it's not approved for MDS. So if no company applies for it for MDS, it
should be president force Amgen and Novartis.
Well, but I mean, the lobby which was made with at the time Teva was for a very good indication, but we have no, we cannot not pressure GSK, that is Novartis. It's more difficult.
I think we can. I think there is a momentum now also from this patient advocate thing, where patients get much more important in the discussion of the interference with companies, and I think it's a momentum to try. I haven't been.
And of course, we'd have to see if, I mean, if this phase 3 trial could be accepted as a clearly, I mean, because there's no increase in AML, etc. That this is what they would, and the same for the Amgen trial with Nplate, and which was never submitted.
Maybe you, as the president of ERN, could send a letter to Amgen and Novartis saying we have to. And no, I mean, honestly, I think we have a kind of unification, East West German unification momentum right now. No, it's true. I strongly also, I think, sorry. So I think we have the momentum from just take this try, maybe. You know, take the ERN as a platform and writing a letter of, you know, you sign it, the Italian group. I mean, we all can sign it and say, please, companies, consider to bring it to EMA to get approval.
Well, I think which should be analyzed perhaps by external experts from our groups is to analyze this trial and see if we think there are no. I mean, it could be submitted to health authorities. But it means the company would have to submit it. It would have to buy the data, which I know is very difficult in Italy, which is, I think, impossible.
I think that's one of the problems. That one was not a registered trial.
It was not a registered trial. What does it mean?
A registered trial.
Register. Yes, but I tell you, I mean, Pierre brought up the APL 0406. This was a trial where the data could not be bought by Teva because it's Gemema. Gemema is not dealing with companies like this. So this is the same here. But I think we have numerous evidence. We have a registered trial, Romiplastim, long-term follow-up, no AML evolution, everything is safe. We have your phase 1, now the phase 2, phase 3. We have our trial, the EMSCO Romiplastim trial. So I think we have tons of evidence, and we apply at the company, at the insurance companies all the time, and they always reject. In Germany, we cannot give it. So The pressure needs to come from the street, as we say. As
You are really French. I'm sorry.
Okay, thank you.
Thank you so much. So we will do the break now because Ariane is not here for the moment. So and we will start again in 15 minutes. On y va? On y va? On y va. So we shall restart. Thank you. So just a rapid overview of the GFM clinical trials. Donc la suivante. So as usual, we'll try to cover more or less all the fields. Suivante. Suivante encore. So first line, we have this oral azacitidine plus venetoclax phase 1/2b study led by Colombe Sayar from Marseille. And the trial actually should have started, and there's a delay because we having some problems with drug supply. So we start at a relatively low level and increase rapidly. So it will be a completely oral formulation for high-risk MDS. Next slide. Second line, next slide. So we've seen the inhibitors. This is the biosite study using a prodrug of RSC. Okay, I haven't shown again the IDH1, IDH2 inhibitors. This is a prodrug of RSC, which is supposedly better tolerated. So it allows you to administer high dose RSC with less toxicity. Unfortunately, the results, I mean, the trial has been led by Marianne Hospital in high-risk MDS and AML that were refractory to all treatments. So results are not very good, and the company decided to withdraw, I mean, application and stop the trial. So, well, it's probably a drug that will not be developed, but on the other hand, potentially was interesting in terms of toxicity. Next slide. So IMPRESS, well, we'll probably talk a little more about it. Imetelstat in high-risk MDS, and it's an EMSCO trial led by Germany first, and Lionel is, of course, the PI for France. Next slide. Allo stem cell transplantation. Next slide. So we have this DACORA trial, which is a preventive trial using Aztec 727, followed by DLI in patients with very high risk MDS after transplant. That is patients who have complex cytogenetic according to IPSSR or TP53 mutation. So you have Aztecs started on day 40 and then DLI. Accrual has been terminated. We don't have the results. I don't know if Marie has arrived, but I'm not sure she has results to present. Okay, next slide. So we have two other trials, Ventograph, which is now venetoclax plus azacitidine plus DLI, led by Thomas and Marie in MDS relapsing post-transplant, and upfront allo in patients with marroblast less than 15%, which also Marie, but no, she's not coming. Marie actually is not coming, but she will participate in the online in the discussion later this afternoon. Okay, next slide. So this is perhaps Thomas, you want to comment, or it's a phase 1/2 study of venetoclax plus aza and the DLI after relapse post-transplant. So next slide, just to say that there are next slide, la suivante. Okay, so it's a phase 1 with an increase in doses, and until now it's pretty well tolerated with a certain efficacy. So next, la suivante. So you have now reached levels. So you will probably open part 2 very soon, and you have already submitted an abstract at ASH, which I think will be a poster. Okay, next slide. So now this is a trial led by Marie Robin, which the idea is to treat MDS with less than 15% with allogeneic stem cell transplantation upfront without cytoreductive treatment. And so we considered it was feasible only in patients with a related donor, HLA matched or haplo, and a related donor could not allow rapid
transplant. And so that's the idea of this trial, which should be activated soon, which is delayed or hampered by what we have in our hospital beds, which is a reduction in the number of nurses, beds closed, etc., which is difficult. I understand it's the same in most EU countries. Next slide. Okay, so it's well, as I said, early transplant. And next slide. The idea is really present things rapidly. CMML has been presented by Raphaël. Next. La suivante. Okay, so Avenir. Okay, next. MDS with TP3 mutation. As you know, there were promising results in a phase 2 trial with APR246, which are not confirmed in phase 3 trial. So it's difficult. I mean, we know also magrolimab failed. So next slide. One suggestion we are trying to investigate is the idea of oral arsenic trioxide, because as you know, in vitro, arsenic trioxide can reactivate some mutated p53, but the problem is that IV ATO is not feasible in this situation. So we're trying to develop with our colleagues at Institut Gustave Roussy an oral form, which could be used first in early trial and then combined with AZA and VEN in MDS and AML with TP53 mutation. So it's a relatively long-term project, of course, but we desperately need a treatment for those patients. Okay, next slide. So lower risk MDS first line. Next slide. This is the trial led by Sophie Park of an early start of EPO in patients who are only mildly anemic before they are transfusion dependent. That's randomized between, as soon as the hemoglobin level is below 10 grams or at the level of red blood cell transfusion requirements, and to see if EPO can delay the disease progression. And of course, this is monitored by Michaela's Fontenay lab and for mutations. Next slide. We don't have the results. I mean, accrual is terminated. We don't have the results. Second line. La suivante, pardon. So this is Le Défi, a trial also led by Sophie Park using low dose deferocyrox in patients resistant to EPO. And this follows in vitro results suggesting some effect at low dose of deferocyrox on erythropoietic progenitors. So once again, accrual is finished. We're waiting for results. Next slide. Suivante. Combola, Lionel has presented, of course. Suivante. We have a registry of following the led by Modevny and Thibaut Conon, a registry led of luspatercept since its approval in Europe, with or without EPO, which EPO is added in case of failure of luspatercept. And there are samples. So I think once again, Michaela's lab will try to make the correlation between response and erythropoiesis, response both to luspatercept and its combination with EPO in those patients. There are more than 100 patients included, but not all had the samples, but quite a few went to have a sample in Michaela's lab. Next slide. And so eventually, patients associated with autoimmune and autoinflammatory diseases, those are generally low risk MDS. Next slide. La suivante. So we know, of course, the Vexas syndrome has been described. So ruxolitinib works pretty well in those patients. La suivante. And just this phase 2 trial, which was led by Arsène Méquignan, found that response was quite good. I mean, 60% both on in patients who had both MDS and autoimmune or autoinflammatory disorders, and azacitidine in this prospective trial worked pretty well on both aspects of the disease. And half of those patients were actually Vexas, and the response rate was the same in Vexas and non-Vexas. So next slide. So the idea is to activate in patients with VEXAS and MDS, both a trial with Aztec 727 with Thibaut Comment and a new JAK inhibitor with Maël for those patients who are not so rare, especially as they are centralized by a group in France to which Olivier in particular works a lot. And we think we could have quite a few of those patients. So next slide. And I think this is finished. And I'd like to thank, of course, all the centers and Fatia Sharmat and her team. So thank you. Je crois que c'est la dernière. Okay, thank you. So once again, some of those trials could become part of EMSCO. I mean, be on various countries. And as you know, now submission is centralized anyway. And by the way, it becomes difficult. And we know it's a difficult task. We have to follow very closely. But you know, that's okay.
What is your experience with this? Hello. It's okay. So you want. So what's your experience? Sorry, it was a serious question. So what's your experience with this portal? You know, with the submission portal.
Well, we should ask Fatia. I know it's complicated.
Fatia.
La soumission centralisée. Okay.
Yeah. It's horrible. Oh. Yeah, French. Yeah.
Tous les nouveaux essais, là on a 3, on va les soumettre avec la nouvelle directive européenne. Et on a déjà soumis un dans le cadre de l'autre association, Euroblonet Association, et on attend la réponse. Ben, je débute. Oui. Ben, j'attends la réponse. On a.
No, but it's hard work.
Oui, yes. Ah non, oui. C'est très difficile.
Très difficile. Yeah. May I say that? So I think the concept behind this platform is good because, you know, at the same time, different countries, reports, blah, blah, so it's one. But I think the maintenance of the system by the sponsor, which we are academic sponsors, requires a lot of people, a lot of work, a lot of awareness, which makes it more complex. And this makes us behind pharmaceutical companies because we don't have the staff to run such a system. This is our impression. So the budget for IITs will go up because you need more people, more study coordinators who maintain this system. Is this also your impression? Maybe, maybe not.
You're right.
Okay. You look for, you need to update critical findings, critical serious breaches.
Who is chairing the session, by the way? Is it me? I don't know.
No, actually, maybe I don't know. Is it me?
It could be. It could be.
Oh, thank you.
Okay.
Thank you very much.
Okay. So I think you're the next speaker, no?
You know, I like the spirit of these meetings because, you know, we present very good data, hard work. We work hard, but we also have fun. Okay, this is, to me, that's the nature of this group. We, I think, also can celebrate and have good red wine maybe tonight together, potentially. Good. So I present the German experience now, or the trials. Yeah, wonderful. What should I say? Judance. Or maybe prochaine diapositive.
Very good.
Je suis un élève de langue français. So, machen die weiter dann? Ja? Next year. Okay, good. Okay, so we have 7 active trials, 2 trials in preparation, and 6 completed. Next slide, please. So this is the list of clinical trials, and Katharina is actually the PI of the Luz Plus trial, and there's a presentation tomorrow. I will she has COVID and will not join here. So I think I will do this tomorrow then. Then we have several trials and I will briefly go over it. You see the flags and that's the contribution or the participation of other countries. Next, please. So, Suzanne. Okay. Prochaine, s'il vous plaît. Prochaine diapositive, monsieur. Merci. Okay, so let's start not with this one because I will present this if you agree on tomorrow because this is Katharina's slide. Next, Suzanne. Whatever prochaine Suzanne is. So this is Lenin. Lenin is the acronym for a phase 2 trial, open label, single arm study, luspatercept in ESA naive, lower risk patients with or without ring sideroblasts who do not require transfusion. So this is basically commands without transfusions and without randomization, just as a brief concept. And you see low risk MDS patients screened, and then we have 4 cohorts. And why that 4 cohorts? Because the expectation is that the response rates may differ according to these cohorts. Number 1, ring sideroblastic positive versus negative, and number 2, EPO level less than 200, EPO level more than 200. So therefore we have 4 groups. And hemoglobin should be less than 10 and NTD according to the IWG 2013. What you also see is that we are quite behind the recruitment. So 5 out of 213 patients. That's where we are now. And I think this is a little bit the challenge we are facing with office-based hematologists in Germany, because those patients, non-transfusion dependent patients, are not at university hospitals. They are rather at office-based hematologists. And these patients have still good quality of life in the majority of the cases. So they are not sent to us. They just kept there as anemic patients. That's a little bit the challenge, but we are still optimistic. Maybe we have to amend the trial or something like this, but that's the current situation. Next, please, as a prochaine diapositive. Then we have the LUCAS trial. This is again a phase 2 study using emavusertib, which is a IRAK4 inhibitor. Some of you, I think, in France also participate in the IRAK4 inhibitor trial in relapse refractory MDS AML. So it's an IRAK4. IRAK4 as a pathway is hijacked by blasts or by progenitor cells in also high-risk MDS and AML, and therefore targeting IRAK4 makes it attractive. But IRAK4 is also important for inflammation in low-risk MDS, and therefore this is a single agent therapy in a wide range, as you can see on the left side, of lower risk patients, transfusion dependent or not, ESA exposed or not. So let's say it's a serendipity all comers trial. And we have 2 cohorts, cohort A and cohort B, ESA exposed or ESA naive. And at the moment, we recruited the cohort A already completely with regards to the futility analysis, which is actually currently ongoing, to see whether we extend the trial and recruit more patients. The next, please. This is CANFIRE. CANFIRE stands for canakinumab in low-risk MDS. Again, but also MDS, MPN are included. So all comers, transfusion dependent or non-transfusion dependent, but anemic, ESA exposed or not. It's basically a phase 2 trial. Canakinumab as a monotherapy study. Recruitment is also a little bit behind our expectations, but we are still positive. Next, please. Then we have ProRed. It's a little bit challenging to read the title because it's in German, but we are an international European group now, so I guess you can read it. So what is the purpose here? The purpose is to assess quality of life, not by signing Q30 forms every 4 weeks while being in a taxi to the outpatient department, but it's a more continuous assessment of quality of life with an app, which is actually designed to do that. So patients on a regular basis. Every second day, they answer questions on an app, very simple questions. And at the same time, and this is actually Anne-Sophie Kubasch, who's running the trial, we also do photographs of fingernails and also the eyelids in order to, but standardized photographs, not like a selfie, so standardized photographs in order to assess the hemoglobin level without needing a blood draw. So the concept to do a remote, let's say the dream of this study is to monitor patients at their home without any blood draw and assess the putative need to receive a transfusion in the next 3 to 5 days just by monitoring quality of life and monitoring hemoglobin levels in the fingernails. So let's say in Germany, it's very common that patients, MDS patients, come to transfusion sites, transfusion centers, if the nephew would like to go for shopping in the city center and just say, well, I need to see the dentist, so I can take you on Wednesday. That's the way it works. So what we want here is a kind of tailored transfusion support, non-invasive. So you open a corridor, and the next 3 days, patient may need a transfusion. Next, please. Then we have Paloma. Paloma is actually a primary comparison of Vyxeos versus, as you see on the right side, standard of care, which is either 7+3 or azacitidine in patients with high-risk MDS in need of transplantation. So it's basically a bridging trial, randomized bridging trial. We just saw the Marie Robin trial without bridging in patients with less than 15% bone marrow blasts. So this is all comers, including oligoblastic AML. So patients 20 to 30% of blasts can also be included if they don't have AML defining mutations, as you can see on the right side. The study is about to be closed. 130. I think we have more than 130 patients now. Hopefully this will be enough. Next, please. Then the IMPRESS for the first time with Australia. So it's France, Germany, Australia, single agent imetelstat as a monotherapy in classical HMA failure patients. So patients more than 5% or equal blasts, relapse refractory to decitabine or azacitidine, and then plus minus actually also venetoclax if that has been given, and then it's single agent imetelstat every 4 weeks. We have now 30 out of 46 patients already reversed. This is the fastest recruiting trial we have ever performed. So there is a lot of medical need for these patients. Next, please. Yeah, and then we have actually also 2 trials in preparation. Number 1 is the magrolimab. It's rather an AML trial, but also includes high-risk MDS. So it's frontline induction chemotherapy for high-risk MDS and AML with intermediate or adverse risk intended to undergo transplant. So induction plus magrolimab. And the other one is the PETROL trial. I think the study was already introduced by Raphael this afternoon. The next. Prochaine diapositive, merci. So, and then we have, of course, trials where we were part of it or we already finished. I just, just to cheer the group, I show that we don't do trials and hide them afterwards. I mean, many of those trials we did together here in this room are also published at high-ranking journals or presented at ASH or other meetings. Next, please. Yeah, thank you very much. Happy to take questions. So I'm the chair. So any questions? Silke is. Yeah. Daniel, come here. Actually, in the first row, we have plenty of room. So our German team is now joining because we had a flight delay. Yeah. Actually, Daniel, it's a good thing that you joined. Sorry that I interact that. But you just defended our proposal, at the Deutsche Krebshilfe, at the German Cancer Aid. So Daniel actually published a paper in Nature Communications of a preclinical application of a novel agent. and which seems to be synergistic with azacitidine. Maybe because you defend it, it doesn't mean it will be successful, but we applied for money at the German cancer. Maybe you can just briefly elaborate. If the trial becomes funding, what will be the nature of the trial?
Okay, hello everybody. I'm Daniel Nowak. Actually, I'll be presenting this tomorrow in detail, but
Okay. I'm sorry. I'm a bad chair, right?
No problem.
I should know. Yeah, I'm sorry for this. But so now I think this will be part of the portfolio of because I just presented our clinical trials in Germany. So
right.
So you meet now Daniel for the first time and tomorrow again. Good.
Yeah.
Thank you, Daniel. Sorry for this. Good. Actually, I have the program here. Yeah. Good. Thank you. So any further questions? I'm a little bit hyper today, right? Maybe too much hyper.
Maybe just one comment. It's for you and Pierre. We are doing in France, in Germany, in Italy, in Spain, a lot of very interesting studies, but all of these studies are phase 2 with a very limited number of patients, and it's related to the funding for sure. But maybe we should think instead of doing, in addition of doing all those studies, doing a larger randomized phase 2 or phase 3 study at the European level. But what we need is obviously funding. And I think the major question is whether we can find together the funding for this type of registration trial, or because we are generating a lot of data, we will generate a lot of data with all those drugs, but none of them will help our patient for the long-term purpose.
I fully agree with you. Maybe that's a very good point for the discussion we have here.
I was talking the discussion.
Already now. Okay. No. I mean, yes, 100%. We also, I think we can do it our own as an IIT, but we just learned also what it means to run IITs. It becomes more complex. My dream is rather, because we care about PRIDE publications, we care about biomaterial access. So I would rather think about cooperative trials where we are basically in the driver's seat with regards to writing the protocol and so on. But let's say all the logistics and so on could be part of a company-driven approach with clear expectations and also negotiations. So rather than doing it our own, I mean, we learned a lot with the Dakota. You know, it's a wonderful trial, but you know, it needs such an effort to run a randomized phase 3 in different countries. So maybe in particular subgroup of patients, or let's say with specific focus on patient cohorts, we may think about strategic scientific collaborative trials with pharmaceutical companies where basically we share our expertise, they share their expertise for a trial, but we actually have also access to data and access to biomaterial. This would be aligning with our goals, I would say, from an academic standpoint. Good. So any further questions? Actually, my program was stolen, so I needed to get the other one. Okay, so now we have Elena, yeah? Yeah, you take this one.
Thank you. So I'm going to present what we have running in the FISIM. Next one. So this is our registry data. Now we have data on 7,700 patients from 67 different centers. And this is the basis for our retrospective study, even if with the limits of our registry data, with missing data and stuff. Next one. So the trials we have, can you go just to the bottom? Next. It's quicker then. Okay, so the lower risk MDS I've discussed before, so I won't go back on that. Then we have just concluded our retrospective study on lenalidomide discontinuation in MDS low risk, and it has become an harmony study. So I will present the data tomorrow in the harmony section. And then we have the FISIM NGS MDS study, which is a study, observational study, going to look in the impact of using NGS at diagnosis and in follow-up of MDS patients. Next, and I will describe what we have, the design of the study. I will quickly present the results of the FISIM luspatercept study. That was a real-life study in the same cohort of the medalist trial. And I will present also the data of a pilot study conducted by Valeria Santini in Florence on the use of oral azacitidine as a maintenance in patients responding to subcutaneous azacitidine. And then we are participating into Patrol and Remark, that is, I think, next one study, but I think these studies will be presented next in the afternoon. So the FISIM NGS study is coordinated by Professor Matteo Della Porta, and the objective was to see if we can go really into personalized medicine MDS. So if integrating NGS can really lead to a difference in the practice in the clinic, and also define the utility of mutational screening in the classification of MDS in stratification, and in the impact of treatment and specific intervention, and then in the implementation of guidelines. Next one. The criteria, the eligibility criteria are quite simple, all MDS patients and CMML. So in this case, we included CMML. And they have to have a biological sample available, and data were included in the FISIM registry. Next one. This is the 48 genes panel that we use for the trial, and the panel was performed at diagnosis and in lower risk MDS every year, whereas in high risk MDS or in patients receiving treatment on every 6 months or every time there was a reevaluation or a progression of disease. Next one. And we have just in July completed the enrollment. We included 882 patients. So we performed NGS on more than 1,500 peripheral blood samples, and the results and the correlation with the clinical data will be available probably next year, late 2024. Next one. Then I will quickly show you the results of the FISIM luspatercept trial. Next, that is a trial that we conducted within Italy in the early access program to luspatercept, and the patient population is the same of the label drug, so MDS with the ring sideroblast refractory or not candidate to erythropoietin. And the endpoints were the same of the medalist trial, so transfusion independence for 8 weeks, and response duration, progression to acute myeloid leukemia, safety analysis above the others. Next one. The inclusion criteria, as I said, are MDS with the ring sideroblast or SF3B1 mutation, low bone marrow blast, failure of the ASA, and exclusion of del(5q) patients treated with lenalidomide or patients treated with hypomethylating agents. Next one. So just to show you, can you do next, because I have some highlight. Next, and next, thank you. So just to show you that our casuistics include 200 patients, and we compared, here I compare the casuistic, demographic and disease characteristic with the luspatercept arm of the medalist trial. And in our real world analysis, you can see that patients were slightly older and had a lot of comorbidities, 67% more than 1 and 20% more than 3. And higher frequency of transfusion at baseline. 7 was the median as compared to 5 in the medalist trial. So we wanted to see in our real casuistics with the old MDS patients with comorbidities, how it was the compliance and if the results were comparable to the registrative trial. Next one. And you can see that the results were quite similar. So 30% of transfusion independence longer than 8 weeks at week 24, compared to 37% in the medalist trial, and that increased up to about 40% in 48 weeks. Also, we observed a reduction in transfusion need that is quite an interesting result for the patients. And we saw an association between the baseline transfusion burden and the probability to achieve transfusion independence with luspatercept. Patients who transfused more at the baseline had a lower response rate and shorter response duration, but this is something we expected. But what is interesting is that this patient achieved anyway a reduction in transfusion need, so still meaningful. Next one. And majority of patients, almost 90%, at some point needed an increase in the luspatercept dose. But half of the patients, particularly the one with less than 6 units of transfusion in 8 weeks, achieved the response with the first step of luspatercept dosage. Whereas patients who needed more than 6 transfusions in 8 weeks needed in 30% of cases the maximum dosage. Next. Last slide just to show you the safety. We didn't observe many serious adverse events. 70% of patients experienced particularly cardiac events. Some acute kidney injury and some falls leading to bone fractures, again reflecting the age and the comorbidities of patients. And IML evolution was quite low, and even the rate of the serious adverse events was similar to the medalist trial. So I think we can conclude that it's safe and the results are reproducible in everyday life. Next. Then I will show you, so I'm sorry that Valeria can't be here because she wanted to discuss with you the result of this pilot study that she has been conducting in Florence on a small cohort of patients with high-risk MDS, aged more than 65, who achieved at least a stable disease response on azacitidine classical schedule subcutaneous or better, so PR, CR, or hematological improvement after 6 cycles of azacitidine. And the objective was to see if there was a feasibility in replacing subcutaneous azacitidine with the oral formulation. The study treatment was 300 milligrams of oral AZA for the first 14 days of 28-day cycle. Next one. Of course, a small cohort, but I can show you the results on the 11 patients that were included in the study. Median age was 81 years old, as you can see, and with a median number of azacitidine cycles was 9. And then when they passed to oral AZA, the median number of cycles was 4. So again, of course, caution, small number, but still we have patients that maintained the response until progression. So they stayed in CR, PR 6 or stable disease 1 until they progressed. And only 4 patients actually progressed to ML after a median of other 9 cycles of oral azacitidine. And 2 patients discontinued the drugs because of intolerance or reduced compliance. But those 2 patients went back on the subcutaneous treatment, and they are still in response. 1 patient died for other causes, so the treatment is ongoing for 4 out of 11 patients. And the safety was quite similar to the subcutaneous one, as we know from other trials with this formulation, with no patient that experienced serious adverse events. And I would like to discuss afterwards with you if we believe that this can be taken forward in a larger trial. Next one. And then I think I'm finished because these 2 trials will be presented later. Thank you. With acknowledgements. Thank you.
Maybe before Pierre, so concerning the are those
No, this is nice also. So it was also a good occasion for our clinicians to get easily access to NGS because towards the CRF, they are reported because it's the same panel that they use for the diagnostic way. Not at the time, it was not designed for that. But also I think we need to perform a way to make more easily accessible the UBA1 screen across Italy. We are working on that. I don't know in your country if there is, you mentioned you have a centralized way to check UBA.
Or those reduce, and you don't seem to
I think this is a valid point you
that,
mentioned. So, okay. So you mentioned the fact that probably this study did not detect common side effects that are less measurable than cardiac event, like fatigue, pain in the bones, that maybe were experienced by patients, but were not reported by physician because outside a clinical trial, probably the doctor itself did not write in the chart fatigue, reporting it as an adverse event of luspatercept. But I do recognize that we experience that in clinical practice, even if not often in my experience a cause of discontinuation, but it depends.
It could be the discussion because I mean, it's not rare. And so, yeah.
It's difficult then to understand if it is related to luspatercept or to the anemia itself or to.
No, but some patients clearly describe the event as being different, and it's different from what they experienced previously with anemia. So
I think this reflects the different attitude in clinical practice and in trial, also when reporting adverse events. It's a crucial point.
Have you witnessed neurological events, rare neurological, also in France or Italy with luspatercept? No? So like neuropathy or some patients pre-syncope, something like this? No? Because there's a debate in Germany now with the GBA, which is the authority who basically reimburses or says that the drug can be reimbursed with a certain amount of money, and taking the medalist trial, also the long-term data, there was a minor signal with regards to these kind of neurological events. So pre-syncope, syncope, neuropathies, these kind of things. And they took it very seriously and said, we rather see an imbalance or disbalance, not in favor of luspatercept. So just in your registry, I think you haven't seen these kind of.
No. But are you giving luspatercept in the hospital or at home?
Outpatient, yeah. Actually, I think in France it's allowed.
So yeah, because this may be another difference that.
Yes. So is it like a nurse coming on a bike through Paris or what?
No, we give it in hospital.
Yeah,
so.
we too. So, but it needs to be cold, right? So how's it? No cold. Okay, so they give it. Okay. And do they check hemoglobin? Do they check hemoglobin? Do they check? Yeah, but they don't check the hemoglobin before they inject it, right? Are they come to hospital the day before? No. Also at home. Okay. So they take the blood, take it then to a lab, and then if the hemoglobin is fine, they inject the other day. Is that the way? Yes. So they see the patient twice. Yes. It's nice. Good. But I think it confirms what you said. I think side effect reports and so on may be a little bit underestimated with this strategy. Would you agree or not? Because, the way we do the. Okay, so you still see it. Okay, good. Okay, so you don't see the patient every 6 months then. Ah, okay, good. Sorry. Good, Elena, very nice. Thank you very much for the presentation. So now we switch to the Spanish group. David, yeah, take this microphone.
Thank you. So, and we have the slides. We in the Spanish group of MDS don't have a lot of clinical trials. I'm not, of course, Dr. Diaz-Campello. Maria could not come here. Next, please. The other one, please. So next, we have 4 main areas of work in our registry. May we have the next? In any case, one of them is, of course, the registry, which is quite large, translational research, some guidelines, and of course, trying to improve with clinical trials. Next, please. Next again, this one. Our registry is now almost 17,000 with patients from more than 160 centers, and this is important because we are having patients from all type of hospitals, not only big hospital, but also quite a small hospital. So we have a good range of different patients' characteristics. In the last 2 years, we are moving to OMOP data type, and now we are including also NGS data. So in the next years, we will have the opportunity to also perform studies having into account this data. Next. These are the numbers that we are including per year, between 500 and 1,000. It depends on the center's activity and how quick they report the data, because this is not performed on daily basis. Next. And most of our patients currently are what we call valid. That this means that we have at least basic values and minimum follow-up. Next, please. The other one. Okay. Regarding translational research, we are now with 2. I'm only talking about 2. Next, please. 2 research projects that we are doing. Apart from these collaborations. Next. The one is Umbrella, similar to Italian colleagues. We are trying to offer all centers with patients with MDS the opportunity to have data from molecular abnormalities. We do this into the Umbrella project, which performs NGS panels in one of 4 centers in the country. And we give them back the results. We also offer some other diagnostic support, but most of the centers are only sending, of course, for NGS data. Next, the other initiative we are doing is trying to diagnose this kind of germline predisposition neoplasms, which are more and more common in the clinical practice. And we have Andres Jerez now working in Barcelona, who is in charge of this initiative, trying to identify young people with MDS and trying to see if these patients have mutations in the germline. And I think this is important, and it's more and more frequent from, at least in our experience. Next, please. Regarding clinical trials, we are working with you in some collaborations within EMSCO and some clinical trials. From our own initiative, we only have in our history two trials. The most important one is the one led by Maria in Sintra-Ref, and we heard Felix talk about that. I'm not going to do that again. And we, of course, collaborate also in industry-sponsored clinical trials. Next, for this part, in our webpage, we have this search for clinical trials, so all the centers can look which is the hospital that are offering a clinical trial that can fit a specific patient and it's near the clinical trial. Because in Spain, there are a lot of small hospitals that are not performing clinical trials, so we are trying to facilitate the patients to be included in the clinical trials, and this is working quite well. You can put the disease type, the phase, and even the drugs if you are looking for a specific clinical trial. Next, please. Okay, just a brief. These are the guidelines we are doing, not only for MDS, also for frontal hematopoiesis, for MGS, general employees position, and some guidelines also for patients. We are trying to start patients group, but this is difficult in Spain. Next, I think this is the ones. Okay, this is just the visit of our web. Next, I think this is the last one. And yes, this is. Is there another one? I don't think so. Okay, thank you.
We have the Dutch group. Arjan actually took over, and he was the pilot because the pilot declined to fly him. Terrible, exactly. You will tell us the story, but also what you are doing with clinical trials in Netherlands.
I will. Sorry to be so late and not discussing with you the details already past, but I really wake up at 6 to be in time this morning. However, due to the terrible weather, it was already 2 hours delayed, the flight. And then we came on the runway and then it stopped and went back to the gate. And then we get, after 2 hours again, we get a very, very old KLM plane, but survived, and I'm here. So, so thank you for inviting me in this group. And although we did not have entered any patient in this collaboration, we still would like to collaborate from HOVON, and therefore we continue our presence if I'm there. And once we get beautiful trials together, I think. So I will start to give you an overview of our approach in MDS as well as in AML. And I will show you some highlights. Next slide, please. And actually, you know, I cannot do it myself, I think. Oh, next slide, please. Okay, if you know, a lot of phase 1, phase 2 trials has been established, and not only our group, but also others have shown that only a marginal amount of trials came into the right panel to phase 3, and at the end survived the phase 3, like azacitidine, like EPO, like luspatercept, like maybe imetelstat, etc., and also the lenalidomide. So that's only that. Next slide, please. And if you look then to what is done in higher risk, and we discussed it in Paris 2 weeks ago, that in the backbone of the HMAs, all those additional drugs failed, and we are waiting the HMA with FEN. So in the Netherlands, next slide, please, we have a clinical basis in which we are a relatively small country, and the high-risk MDS is always treated as AML. And it's still a question in our group whether or not it is good, but this was a tradition. And this is actually the basic scheme in all our trials regarding high-risk MDS. We have an induction scheme with or without an experimental drug. That could be clovarabine in the past, lenalidomide in the past, or other drugs. And then based on the definition of risk according to AML, not according to MDS yet, but it will change. The good risk based on MRD goes to a consolidation by autologous transplants or by conventional chemotherapy. And if they are MRD positive after the second course of treatment, they move on to allo. The same holds true for intermediate risk, according to the definitions in the ELN classification. If you have still MRD positivity after the second course, you move to an allo. But if you have an MRD negative state, with a validated assay centrally assessed, either molecular or by flow, you go to an upstage, less toxic autologous transplant. And the data are quite okay. Next slide, please. Next slide. So the backbone is quite similar. The HOVON 132 was the last published to date. Backbone you see, then we had with or without lenalidomide. The next slide, and then you see the outcome of those trials. This is the last trial which is published yet. Next slide, please. And if you saw no difference between both groups, but no dissection into MDS or not. And tomorrow I will show you data on MDS within this cohort, how they are performing. Next slide. So after this trial, we have several other trials with high-risk MDS as well as AML. We have the HOVON 156, randomization, the backbone 7+3, with either midostaurin or gilteritinib in all those FIT mutated. This trial is just closed, and we are waiting for the results. The second trial is the same backbone in those who are IDH1 or 2 mutated, either EFO or enacitinib. The enacitinib is just closed, that's placebo-controlled. So if you are mutated or not, either EFO or ENA versus placebo, and the EFO is still open, almost ready. So data are coming soon, or we need 2 years for that. At the rest, if not FLT3 mutated or IDH1 or 2 mutated, you are in the rest group, and then we are still not open the 7+3 backbone with or without venetoclax. We are doing a running in phase with the German group, and we are waiting how to move forward whether or not it is visible at the end. So this is the backbone. These are all in the fit patients, independent on age. Fit. So if you are 75 or even higher and you are fit, you get this backbone with or without the drug based on molecular profiling. Next slide. Then we have several studies in the, the PI is Mark Rijmakers from this study. Next slide is the backbone of the FLT3 mutated. Next slide. Then Bas Wouters is doing the EFO and enacitinib trial. So always the same backbone with or without placebo-controlled, in this case EFO or ENA, dependent on the consolidation therapy, average still LO or auto-consolidation based on MRD, etc. Always the same backbone. Next slide. So the unfit patients, independent on age, so also patients of 60 years old, but unfit according to specific algorithms, can still go in this kind of trials. We had the backbone of decitabine, and dependent on the blast clearance after the first course, we can go down to the scheme of 10 days to 5 days and so on until progression. But on that backbone, we add, for instance, new drugs. In this case, the 135, we added ibrutinib based on in vitro data that it might be of interest in specific minor subsets. So the data of these trials in the next slide, this is already finished and the data are published yet. Next slide. No difference. So on that backbone of decitabine, no difference in unfit patients not fulfilling the fit criteria for doing the other trials. Next slide. The same holds true for this study. It's closed. However, the data are now in analysis. The same backbone, decitabine, and then independent on the FLT status, FLT status, whether or not mutated, we added midostaurin. The study is also full now, closed, and we are waiting for the data. But remember, this is our standard backbone in unfit, high-risk MDS as well as AML. Then we are different new approaches, and I think that could be discussed here. Next slide. So we also work in the so-called EVOLVE consortium together with the AMLSG as well as the UK group. And we first started with the development of the enhanced of the EVOLVE study, in which we add magrolimab to the backbone of azacitidine, but it's now the enhanced 3. And you are aware of that. It is on hold based on a possible toxicity. But then we are developing, but not yet running, next studies, including EFO, including menin inhibitor, as well as including cobicistat. And I will show you the concept. Next slide. This is the HOVON 173, not running yet, but in development. So patients who are unfit, not considered for intensive chemotherapy, no allo consideration, baseline. We have the backbone, in this case, of EFO-AZA in those who are IDH1 mutated, plus or minus FAN. This is a new study, and I think that will be run quite soon. plus the basis. Next slide. Then we have to study the Hovan 171 in the next slide. So this is for the IDH1 mutants. Then we have the study of cobicistat plus FAN. And cobicistat is an inducer of the CYP3A, like posaconazole does. And this is a study, not internationally, only in the Netherlands, based on the fact and paid by the government, so-called transformation money, to make it a little bit cheaper for all the new drugs, because we think that the amount of FAN can be reduced at least maybe 8 to 10 times. So to make it very effective, cost effective. So this page by the transformations money in the Dutch community, and to a control, because it is not randomized, it's a single arm, we have the comparison of daily light registry by our cancer registration. So basically that is also, I think, interesting. It's not open yet, but that is the concept we are working on, also in light of all new drugs, and it should be payable at the end. Okay, next slide. This is the scheme, for instance, for that cobicistat. We have a run-in phase with azafen as a backbone. Then we lower the FAN dosage and then come in with cobicistat. But also there's a running-in phase independent on the kinetics, etc. We move on later on how we can combine these drugs, because cobicistat is very cheap, and also in the context of other infectious diseases, it is generally used in the Netherlands. So a well-known drug. Next slide. This is quite interesting and new, the so-called MINIM inhibitor, especially in the MLL rearranged in NPM1 mutated acute leukemias. And by adding the MIN-HIN inhibition, you get an inhibition of the gene transcription based on interference. And there's a new concept, and especially in those mutated acute leukemias, we will perform this trial. It's not open yet, but on the construction. Next slide. And it is all based on quite interesting recent data published in Nature, for instance, in which they found as a monotherapy, quite good responses, specifically in this kind of mutations and MLL rearrangements. Okay, next slide. This is the scheme we are working on. Azafen as a backbone, with or without the menin inhibitor revumenib. Always the same backbone, with or without placebo-controlled, the drug of interest. Okay, next slide. This is a summary of what I told you. You know, we have the backbone, always the same, 7+3 in the fit patients independent on age. And then we have the backbone of the unfit patients, not likely to go to an allo consolidation, but unfit also independent on age. We developed the IDH1 mutated cases like we did in the fit patients. We need a lot of patients to screen to find those. The EVOLVE study, AZA-EVO as backbone with or without FAN. The specific menin inhibitors regarding specific subsets of patients. The rest of the group without those mutations, AZA-FAN as a backbone with the cobicistat to make the cost a little bit lower. You know, the enhanced 23 is now not within its consortium specifically, and I discussed not yet the TP53 mutant in which we are working on the oral vitamin A compound. So that's what I would like to give you a little bit idea how we approach MDS in the Netherlands. And I did not go into the details on the lower risk. It was in my presentation. I was in the plane. Okay.
You know, that's the concept of this meeting. So thank you very much. The first question, Elena. Actually, microphone would be preferred. I bring it to you. No. You need the microphone.
Thank you. No, I was just wondering if you did any stratification between MDS or ML, or according to new classification, you just then analyze them all together.
As you know, I'm really heavily involved in the MDS community, but I also have been heavily involved in those senior guys in the past. They are still very active. And the discussions about AML MDS was not easy, although I am a little bit mature in age already. It was not easy. However, we now are in this within all HOVON trials together. Tomorrow I show you some data about that, in which we try to focus on that in well-described prospective trials, whether or not MDS do really differently in those settings. And these data are very intriguing, as you can imagine. But now we are a small country. What to do with trials if we not spread to our friends here in the room to make the higher risk separately from that and make it happen in EMSCO or with the other groups? So exactly. I think it is a different disease, although molecularly defined nowadays in a spectrum. I still believe that MDS, and I think you also, otherwise you are not sitting here, is a different disease. It's really a stem cell disease and not a stem cell disease alike, and therefore should be have a different approach. I think we agree to some extent.
Maybe something for this, let's say, chair discussion. And, you know, since I think my suggestion is actually we sit down now and yes, yeah, exactly. Just now summarizing. So because I would like to ask you a couple of questions, and this would be the incentive for the others to, but I will actually moderate the session. So Lionel should be here, Elena should be here, Maria is not here, David should be here, Pierre, Thomas.
Oh, yeah, that's right.
Yeah. And yes, yeah. So we sit here. So we need now definitely more microphones. So these microphones are so-called seismographs. You know exactly where you are, you know, now you're on the safe, but if you go like this, okay. Anyway, so now, Arjan, I think you nicely showed what the HOVON is doing, and the HOVON, Bob Löwenberg, Hartmut Döhner, also the drivers of the ICC classification, and I think there has been tons of debates at meetings. Is MDS, high-risk MDS no longer existing, MDS, AML, you know, I mean, basically we can actually switch off this so it's less light, but anyway. So, I mean, I think that's strategically a very important point, and also should we homogenize efforts here. I think the HOVON now is, and also the AML-SG is going into the direction MDS, AML does exist. It's part of either non-fit protocols for AML, or it's other part of fit protocols for AML, where even transplant. So is this something where you also personally agree this is the way to go, or is high-risk MDS still another disease? Yeah.
Actually, what they did in the past, and I worked also on that similar to trial, so also I'm adept to that. If you really, based on the criteria we used in all those HOVON trials in those days, all the WHO classification, and we split them based on that definitions, MDS do always bad. And I showed you in Paris 2 weeks ago the slides, and I will repeat the part tomorrow. They are worse. But now we are working on the profiling genetically, whether or not these really at first MDSs are also worse based on genetic profiling, and thereby the continuum is maybe right. If you look then also to whether or not after the second course of this kind of high-dose chemotherapy with or without an additional experimental drug can be guided based on MRD, then the answer is yes in both groups. However, still MDS, according to high-risk protocols with an MRD negative signal, do even worse. And MDS with a positive MRD status is similar to those AML with a negative MRD status. So from that perspective, it is suggestive that it is still a different disease. So then in the development of either the WHO 2022 versus the ICC 2022, I'm lucky, or we are lucky that the WHO does not implement that yet. However, we know all discussions also in coming age about the harmonization of those two systems to go into a purely molecular direction. But if you look also to the outcomes, a real MDS cannot be cured by an autologous transplant. However, in our trials, a lot of MDS patients are actually cured by an autologous transplant. And that is interesting. So the question is, why? Were they actually MDS, or were they really AML signatures? And are they a more mature differentiation blocked problem? Do you understand what I mean? So the question is, I still are a believer of a real stem cell disease and thereby only cured by allo and thereby a different approach. And if you look to most AMLs, except some, are a little bit beyond the stage of the really stem cell definition and thereby should be treated accordingly. So it is debate. So I'm looking forward that I think to answer this question, really we need single cell analysis, and several of ours and others are working on this approach to make that issue.
Do you want to say something, or do you want me to say something? Yeah, you know, I think I fully agree with you that it's at the end of the day, it's all about molecular biology, which I think is the
immunology, I hope.
And what?
And immunology.
I mean, immunology is the basis.
I hope.
You know, and then comes, of course. No, but just joking. But of course, it's you know, it's a holistic thing. But I think the current wording of the ICC to me is a little bit too much simplifying maybe the things. And I think we as an MDS community, we also witnessed that. I mean, if we would have claimed that AML belongs to MDS, you know, we from our part, I think the AML community would have been a little bit unhappy about it. But the way the, let's say, AML community now hijacks, and I call it like this, also with clinical trials, the high-risk MDS, without involving, let's say, the MDS people.
Right.
I think this is a little bit, to me, and I'm now getting a little bit, well, emotional here, but
then we should prove that based on whatever the science might be or the outcome of the clinical data, that they actually do differently.
No, I think we should work together.
This
is my consequence, and we, you know, in a polarized world, and again, I'm looking at you, and don't take it personally, you know. But I think in a polarized, I think these two classifications are a reflection of a polarized world, as we are, and this is sad, you know, because how could that happen? This is a little bit the sad point behind. Yeah.
If I just may add quickly, I think also that pathogenesis and prognosis and response to treatment are different subjects. So we may say that MDS are different in diagnosis, are different entities, but still they may respond to the same drug. So I think that we should look at it in two different ways, separate the disease because they may have a different course, different biology, but still the number that you may have putting together MDS AML won't be the number that you can have using only MDS, and then also giving access to new drugs to MDS patients. I think it was one of the aim of the ICC guidelines. I don't know if I may.
If I may. I don't think that they respond the same way.
No.
So it's different diseases for sure.
That.
And we might, I think, on the MDS side, to do a classification with RAPE 3, RAPE 4, RAPE 5, RAPE 6, up to RAPE 10. That might be also, it's a, yes. And then RAPE 9, starting at RAPE 9, it's a leukemia. But, you know, we are distinguished the two diseases by a threshold that is totally artificial, you know that. So we should make the difference by biology and response to treatment. And for sure, the response is totally different.
not only the response, but duration of response.
Toxicity probably.
Well,
also.
I don't think it's related only to toxicity.
So
You know,
don't
if you
think-
transplant a patient with MDS, the relapse rate is higher than AML. It has nothing to do with toxicity. Age, of course, might influence the toxicity, but induction chemotherapy is not more toxic in AML than in MDS or the opposite. Still, well, the age, of course, might have impact, the age, but not the disease. But the complete remission rate is totally different, and the duration of response is totally different.
Yeah. I mean, it's true that you don't have the same response to intensive chemotherapy depending on the percentage of blasts. This has been shown a long time ago. So by adding patients with less than 20, you actually, the risk is blurring results of interesting drugs that are not going to work in MDS. And that's the main risk. You put everything. If you test ATRA on all AMLs, you will have 10% response, but that will be all APL. That's the issue. And the same with mutations, by the way. Do you think it? Well, we all think it's not the same to have MDS with their 5q and two small TP3 mutated clones, which should be called biallelic TP3 mutation, and a patient with a 4-line karyotype with including 17p minus, 5q minus, with no more normal P53. He's also called biallelic. They have nothing to do, but they're classified in the same category. So once again, you're going to blur totally results of a clinical trial by putting everyone together. The problem is that some physicians who are not senior are going to take your classification and apply it bluntly to patients. And also health insurances are not going to pay because, you know, you have this and this, you cannot be transplanted. On the contrary, you should be transplanted. That's the issue. And I mean, we have to be more practical and take subtypes. For example, this morning we talked of IDH1 mutated MDS. They respond very well to single agent ivosidenib. And so they probably should be taken out of MDS groups if you could, for example, test AZA plus Ven, because, you know, that's the issue. So let's try to go away from those classifications. The problem is that people who don't have a very large experience are going to use them. So, and especially if there are two that are contradicting each other, that's a big issue.
It was actually also the basis of EMSCO, and to make our power in the field more broader, also in numbers, that we can identify subgroups, and thereby on our own, and especially I speak for HOVON, cannot apply any trial based on the numbers. But if you identify those entities which might be specifically targeted either by molecular targets like EVO or immunological parameters or whatever the drug might be, that should be the strengths, and thereby we should collaborate. And I think Uwe, as one of the founders together, was the initiative of EMSCO Group, was it?
I mean, it was the incentive was to come to places like Nice and so on. I mean, you know, but of course, patients. Okay, no, but yes, I fully agree. But I think to identify those subgroups and also to harmonize, I think these are the issue. And may I ask Thomas here in this forum, because we talk about P53 as a potential common target. So Thomas, from your experience, I mean, you published first author JCO and, you know, everything. You were one of the pioneers with this magrolimab. So why do you think, I mean, magrolimab is an example of early clinical trials in high-risk MDS, super duper data, everybody is convinced, and then phase 3 fail. We have other examples, Lionel, pevonedistat, you know, so why, what?
You said, you know, I said, I know.
Okay, yeah, okay. So, but you know, I would rather go start with Thomas, you know, with the P, because this is what relates to what Ian says, that we have to find, let's say, a commonality across blast thresholds, which drives also disease, not only biology, but also prognosis. And then this makes sense for to have trials across blast thresholds and so on, which I think you did also with the magrolimab. So I think patients had wide blast range from 5% to 30%, and the response were much less in the AML, whereas in the MDS it was great. So maybe just some thoughts, why did the magrolimab program fail?
Yeah,
so far.
So I totally agree about to work only on maybe molecular subtype, but totally agree too that MDS and EML are probably not the same disease. Today, we fail with a lot of drugs, so the pevonedistat, the magrolimab, as another drug, but I'm not sure these drugs are not efficient. I think we are not efficient, we together, to show that the drug was efficient. I think we the EMSCO, and we have to work together to maybe change our design of clinical trial. Maybe we have to change also the criteria of response or the primary endpoint of our study to identify maybe a subgroup, maybe more stratify the population about molecular subgroup. For the magrolimab, I don't know why the clinical trial is negative, but what we know today that there were more TP53 mutated patients included in this clinical trial than the usual population. So this is the first point, and I'm not sure the statistical analysis at baseline included that we will include maybe 40 or 50% of TP53 mutated patients in this clinical trial. So of course, the control arm is not the good control arm, and at the end, the clinical trial is negative. So it's why maybe we won't have to work on heterogeneous disease, but maybe more, and it's why we have to work together, because if we start to work on a little subset of disease, we need to work together.
Yeah. Well, I'm repeating myself, in fact. So, but I think we are usually too optimistic in our clinical trial design, especially those coming from the industry, but also from our group. And we are enrolling few hundreds of patients. That is not a large number of patients to have a survival advantage, and our expectations are too high. For example, in the APR trial, it was expected that the complete remission rate doubled. In the pevonedistat trial, it was expected that the event-free survival will increase by 8 months. Have you ever seen in solid tumor a trial enrolling 300 patients that might expect to have a gain in survival, even event-free survival? That is almost more than 30%. The hazard ratio are insane. So at the end, whether the drugs are ineffective or are we too optimistic in the way we are designing with such an heterogeneous disease, by the way, because if you look at P53 proportion among trial, and we know P53, but there are so many that we don't know that might induce heterogeneity among those diseases, that I think we are going in the wrong direction. And at the end, one will be maybe positive, but it will be by chance.
Yeah, but the thing in the PEV trial, I still don't understand where it was the fail, because I agree that waiting for 8 months or event-free survival is too much, but the thing is that there was not even 1 month. And the thing is that the response rate in the phase 3 comparing with the phase 2 was crazy big. And so I don't understand. I was also involved in the trial, and you know.
So believe me or not, but with Michael Seckers, who are co-leading this study, we have asked all the analysis you can imagine. All of them were negative. All. Tons of analysis. And I don't know why. I really don't know why. Maybe the drug is ineffective.
But how can it be that the phase 2 was, I think the response rate was, or in the randomized phase 2, the CR rate was almost 50%, right?
Well, in the phase 2, there was nothing that was significant. You have to keep that in mind. Well, in subgroup analysis, yes, but and there was a doubling in the duration of response, an increase in the response rate that was almost significant, but the duration of response was very nice, exactly the same as the result presented with magrolimab, by the way, with the same design of the slide. And a prolonged event-free survival that was very nice on the curve, but that was not totally statistically significant.
But could it be that in phase 2 and phase 3 trial, because of the heterogeneity of MDS, we're not targeting the same population?
What is of interest with that study? Because usually when you're discussing trial with azacitidine, it is very common to say, yes, no one can recapitulate the AZA 001 trial. Yes, this is the Spanish mantra, and I can understand that. But at the end, in the PIVO study, we totally recapitulate the results of the AZA 001 study. So there was no biased selection, maybe in a way that we were too much in favor of azacitidine, but this is the way it is. I have no other clue.
No, I think we have to be careful indeed. For example, the magrolimab was typically the trial done with the worst patient. Why this enthusiasm for TP53 mutated patients? The survival has never been more than 12 months. It was obvious from the beginning it was not working in those patients. So there was an enthusiasm, and so they put the worst patients. And so you don't expect in the worst patient an effect of magrolimab. So that was the first mistake. The phase 3 trial, another bias, the phase 3 trial with APR-246, what actually happened was that clinicians who had their patient treated with in the conventional arm found it was not good, did something else, including chemotherapy transplant. And so introduced a bias between the two. And that, because that went through FDA and quite a few, and that could have biased and actually prevented a survival difference. Finally, we have, of course, the response criteria, which fortunately have changed because they really underestimated the CR rates. And we have also the endpoints. A good example, if you take survival, I mean, a good example is AZA plus enasidenib in AML. So people say there's no difference between AZA and AZA plus enasidenib, but median survival is 22 months. What happened, obviously, is that in the AZA arm, all patients received enasidenib when they could after failure. So if you take into account survival, you say there's no interest. But if you take now into account progression-free survival of event-free survival, you have one. So, and all this, it can introduce some false positive results, which are problematic. In particular, well, I mean, in a way, I don't know if magrolimab is effective, but it's been killed by this TP53 story.
So we have, if I may ask the group, 3 major issues. 1, we should have a modus to speak with our AML freaks in a structural way how to approach this. Secondly, we should define, based on our current knowledge, which is still every day evolving, how we approach selected patients with new emerging drugs based on knowledge, based on biology, based on immunology, based on molecular biology. And therefore, I think we do have strong think tanks. And the third I forgot it. But I think, but I think, yes, that's always the most important. But I think these are opportunities, and as an EMSCO group and with an European group and all the others, we should have that power to discuss that structurally and then have the good arguments, and not as we did, based on we are a small country and thereby only 10 to 15%, although we have in all those trials in 4 years always 800 people included. 10 to 15% are MDS. So in 4 years, that's approximately also quite amount, but we can do it quite rapidly with the appropriate endpoints. And that was your point, Pierre, not to evade the good drug away because it cannot be done based on the endpoints giving any result.
Fully agree. I also, to the comment to both of you, I think sometimes it's also us carrying a concept of a pharmaceutical company. And again, pharmaceutical companies have different interests than we have. And concerning the P53 story, you know, it's of course fantastic to believe that with your drug you're gonna maybe cure P53 mutated MDS and AML at the same time. I think it's a wonderful concept, and you can get up in the morning, go to work, and you are basically, you know, you are thrilled to be part of this company. But to me, I was not part of those trials from the very beginning, but I was rather a silent observer. I was rather a little bit critical in this overall concept, and I actually told it also to the company. But at a certain level, and we think back in the old times of iron chelation, you know, at a certain level, a company spirit detaches from the reality. And what I want to say here is that because we sit in these advisory boards, very often it's also our responsibility, apart from what you said and Pierre said, to bring these companies also down to earth at some point, because sometimes they are like Scientology, you know, like no, it's true. And again, there are people, and I'm not blaming pharma in general, and don't take it personally again, but this is my experience in 20 years of clinical research, that sometimes you enter a room and people don't see the reality anymore. They just see what they want to see.
No, just about P53 mutated, I mean, it made sense for APR246, which indeed in vitro it can reactivate P53. I mean, this has been shown. Now, it did not, you know, it was not confirmed in vivo, but that made sense. Now, for magrolimab, the company came just with the drug. I mean, and then some investigators treated 10 patients with TP3 mutation, said it was great, and they put the hype on the company. It did not come from the company. I mean, you know the story like I do, and then the company followed, but it was not initially the company. There was some hype. Some of our colleagues tend to, you know, to include relatively low risk patient and then claim a fantastic CR rate. And they are generally on the other side of the Atlantic, we have to say. And the result in magrolimab is typically the story with it did not come from the company. Yeah, this high.
Yes, but you know, but I think the way the pharmaceutical companies work, and again, this is, I'm not blaming them, but they need a kind of path and the kind of wording and the kind of energy, also buzzwords, you know, which drive a certain product and which differentiates them from other products. And I think they embarked on this strategy, maybe forced by investigators, because they also were interested to embark on it. So it's, you know, it was a basic self-fulfilling prophecy, and which unfortunately now burned a lot of money and also involved a lot of patients who would have been maybe eligible for other trials. But again, all I want to say is that we need to be sensitive to these developments, and I think counsel with companies in a fair way so that they target the right patient population. Lionel, do you wanted to say something? Because otherwise I had to come. Yeah, no. So because maybe the clue is immunology, you know, and it's, you know, because now we embark on blast count, you know, we stratify for cytogenetics, we start to stratify for molecular, but maybe we have to take into consideration flow cytometry. And this brings me now to the next point here. Yeah, of course, how to integrate flow in diagnostic and prognostic. No. But Marie Robin will be here at 6:15. Not, she's already there. No.
No, she's not. She's not coming.
Yeah, I know, but she will not be here before 6:15, I guess, virtually.
But perhaps to have a formal presentation on
I mean, well, as you want. Do you want to have a formal presentation on P53, Thomas? Yes, exactly. Yeah. So and. Yeah, exactly. No. This was I was now planning to, as a next step, to have a presentation, you know, by Orion.
Orion.
Yeah, Orion on flow, and then we discuss immunology and integration of immunology into clinical trials. This was the concept, and then 6:15, Marie Robin is coming.
Okay, and we have a presentation together, and Orion, I think I was starting the first slides, and then you actually it's okay because we combined it. Yeah, but it is not on immunology in terms of what you are thinking, and maybe we can highlight that there is an international integrative immunology working group as part of the scientific working group on MDS just started and led by Shahram Kordasti. And that's really on immunology. And there will be a position paper soon. Dorothy also, yes, yeah. There will be a position paper coming out on behalf of that new established working group. And Uwe is also in part, Lionel, you are in part, several of us, not you, huh? Not yet, but Miguela is a part of that. I saw her. So, and there's a group, actually they are working on the immunology from the early clonal hematopoiesis towards clonal evolution toward AML. And the goal of that group is to try to identify really immune profiling, looking to both innate and adapted immunity. But this story is not about that kind of immunology, but it is about how to use flow cytometry in diagnostics, even in prognostics, and maybe in predictive of response. And the prediction, I will maybe highlight it a little bit when it's time, because it was in my former presentation. So may I have the slides? It was, I think, C5. Was it? C5. Code that. Oh, yes. So I have only some slides, and the question from the organization was, how can we apply flow cytometry in the diagnostics? And you both will go towards the monocyte part, and I gave a little bit an overview on MDS, which is not CML per definition, but there are some overlap, as you know. Next slide, please. And I will highlight that the working group started by doing this more than 10 years ago within the European Leukemia Net. And now I will discuss with Lionel and Uwe later how we can integrate it also in a scientific working group of EHA. And what are possible the major problems in MDS diagnostics in patients with cytopenia who came in a routine base in a peripheral hospital or in academia, doesn't matter, with only mild dysplasia and no molecular abnormalities. So that is based on the fact that if you have a really a low risk MDS, almost over 50% of cases do not show a cytogenetic abnormality. And also mutations, mainly the chip-like mutations, did not define MDS, can be seen as a clonal hematopoiesis in general by aging, or is also part of other milder diseases. So you cannot define MDS by doing this only. And note dysplasia by looking at the microscope. Who is looking to the microscope on a daily basis as a hematologist? Lionel, you do every day. No, not enough. That's terrible because it is so really tricky but you have to count at least 500 cells to look carefully, are they dysplastic or not? And nobody looks to 500 cells under a microscope. So it is really a problem. So it is a subjective, it is inter-observer variability, and it's also involved in all kinds of other diseases, viral infections or whatever, nothing to do with MDS. Second slide. So what we've done is to ask ourselves, how can we now integrate flow as an unbiased method in which you have in 30 seconds millions of cells to look carefully whether or not these cells are different from normal. That means they are not as a comparison to normal hematopoiesis. So really dysplastic in terms by flow cytometry, not by our eyes, objective, and also we can do fully automatically without any gate. If you are a flow cytometrist, you know that there are also some subjective methods how we identify populations of cells. It can be fully automatically without any bias. And what we've shown within the work of the last years, it is published in 2 major issues. It is encountered 14 papers, I think, Oriane, by doing these analysis. And we showed that if you find by a flow analysis more than 3% of myeloid progenitor cells, which might be equivalent with blasts, although blast is the microscope, and this is based on immunophenotyping, this is highly likely to be MDS by definition, at that cutoff level. Furthermore, in analogy with the so-called leukemia-associated phenotype, which we drive clinical decision-making in AML, also we can look into details on CD34 positive cells in a low risk in any patient with a cytopenia, maybe only 0.5% or even less on CD34 positive cells. But if these cells are aberrant, that means they do express antigens which are normally not expressed on myeloid cells, lymphoid antigens like CD7, CD5, CD2, or whatever. It cannot be a normal situation, and thereby it's a leukemia-associated phenotype. And it's aberrant, and that is underlying myeloid diseases. And it can only be 0.5% or even less, and you can easily detect. Furthermore, you can find aberrant differentiation patterns in the more maturing settings. And what is very important is that until now, we do not claim that this is the sole method to replace microscopy in this kind of field, but it should be integrated in an integral report. Next slide. Next slide, please. So don't read this, but after a lot of work, years by several of us, we defined the most key parameters which are able to identify the myeloid progenitor cells, not only the amount. It is not a problem if you have 6% of blasts by the microscope and some dysplasia, although not more than 10% in the lineage, to say it's myelodysplasia. But if the counts are low, then you need additional markers, the so-called leukemia-associated markers, and different from normal markers. The lymphoid progenitor cell compartment, although also low by aging, however, is also important in our MDS group of patients. Then we have markers for the granulocytic, the monocytic, as well as the erythroid series, as well as those other very low frequent cells, which also are of interest, mainly also the mast cells. And I think tomorrow morning we have a talk about it. Yes. Next slide. So the main paper of last year is that we had a huge database of over 1,500 patients, and together in the working group, and therefore EMSCO is important, therefore the I4 MDS immunology group is important, therefore this group is important. We do it together because we gather well-documented patients to highlight which are the most important markers, which are the cutoff on the level of blasts, which are the most important immunophenotypic aberrances, which are the most important on the most maturing cells. And we came up with 17 markers, which will now prospectively validated independently, also with the backbone of molecular aberrations. That's the next project we are working on. Next slide, and then I'm almost finished. The problem always is how we can then translate all our markers, which can be fully automatically also within some minutes, translated to a score, which can be sent to the integrated reporter and to the physician at the end. Don't read it, but by this scores, we are able to have a B, a C score. That means A, the flow cytometric assessment by doing these panels did not show any signs of dysplasia. The C score means, dependent on an amount of aberrancies, means that it is highly likely to be associated with MDS. But note it should always be reported in the context of an integrated report. And B group should be the most small group in which you don't know. Yes, and in the group of Uwe by Uta Urschlegel, she tried to have all kind of integrated, all kind of flow scores, and in her independent group, that was the Dresden cohort, she showed that the integrated flow score was the most sensitive and specific score by doing the assessment. And we are lucky, we developed the score, and the Dresden group could validate it. And so we are very happy with that. But now we are trying to validate it also in independent groups. Final slide, I think. Then I came in with the algorithm, I think. And then Oriane and Dorothy may continue. Next slide. Then we built on the algorithm, how to use in clinical practice. And that was the question I came here, is that a patient with a cytopenia, and you can directly rule out that it is based on a lymphoma, an hairy cell leukemia, an acute leukemia, or whatever, you are already there. So the starting point is look under the microscope, add flow cytometry simultaneously because of the exclude B-cell clonal hematopoiesis or whatever, and then make the decision to go further on how to make an integral report at the end. So not by doing by any cytopenic patients the whole morphology always, but then also make a decision tree based on cytogenetics, molecular genetics, as well as on flow. And this scheme is quite helpful to go into a clinical laboratory practice on a daily basis. So the final slide is to thank a lot of people working for years in this program. Last slide, please. Oh, not yet. That is on the. These are the challenges. So it is not closed, the subject. We are doing validation trials. We are now working on a one-tube approach. That means that we need quite hypocellular samples also to make also a one-tube easy to handle, 24 color or even more by spectral analysis, new technologies. We try to set up that now in different labs. We further validate the computation approaches to make it easier without any subjective interference with the system. We are working on prognostic models, and also Jérôme Kodasti, Ida is not here. She will present in another setting. The data have proven also that this scoring system is also of prognostic significance beyond IPSR. But the question is it also prognostic beyond IPSS molecular? That are main questions we still do not know. We are looking into leukemic stem cells, and we just discussed it in a month how to continue with that. And also in other issues, whether or not it can predict response to either lenalidomide or to predict response to luspatercept or other drugs. So that are future directions, and these directions are important to select the appropriate drugs in specific settings of patients. Like len in the non-del(5q), for instance, len in a non-del(5q) is not effective if there is an SFW1 mutation, for instance, or in specific immune profilings. If you have enough progenitor B cells and high lymphocyte count in the total bone marrow compartment, you do respond quite good on lenalidomide in this kind of settings. So these are predictors. So final slide. And we thank a lot of people working in this context, and we continue and are happy to discuss you later how to continue within also the scientific working group on MDS.
So next slide, please. So now I will talk about flow cytometry in CMML. So I will do the diagnosis part, and Dorothée will do the prognosis part. Next slide, please. So flow cytometry has made its entrance in both new classifications. And you can see that in the WHO Now, an abnormal partitioning of peripheral blood monocyte subset is now recognized as the supporting criterion for CMML diagnosis. In case of classical monocyte accumulation exceeding 94%. And the ICC mentions, you can see in red, an abnormal immunotype consistent with CMML would be required for its diagnosis. So one can think they do talk about the abnormal accumulation of classical monocytes. So since our first report in 2015, next slide, please. Next slide, please. Sorry, I've made an animation. It was not a good idea. No, oh, okay. Okay. 2 years after our first report, Eric Padron's group confirmed our results with the same good performance with the 94 threshold. And then we conducted a French multi-center study with using data from real-life conditions, and we again obtained good performance. And I conducted with Ariane within IMDS flow group a multi-center study with 10 participant center, and we again challenged the 94% threshold and obtain the same good performance. And in France, since 2018, we set up with Dorothée a dedicated working group, flow cytometry working group called CITEM LMNC. And we set up a program, an inter-laboratory comparison program in 2020. And we have the 47, sorry, I'm a bit tired. 47 French-speaking registered centers who participated. So it was quite a great success. And last September, we led with Dorothée a dedicated workshop at the European Society for Clinical Cell Analysis meeting with 26 participants from European and international countries. Next slide, please. So I just want to focus now on a new feature shared by the BOS classification, which is the decrease of the historical threshold for monocytosis definition. And you know that now we moved to 1 giga per liter to 0.5 giga per liter. We already speak about that with the question of Michaela. And I just want to say that we previously showed that the median value of monocytosis from nearly 200 healthy donors was near 0.5 giga per liter, and with an extrapolation, mathematical extrapolation, we demonstrated that we nearly reach 0.6 at the 100 age. So probably the historical threshold was overestimated at 1 giga per liter. And you know that in 2017, a new entity called oligomonocytic CMML was in fact defined. And this patient were MDS patient with relative monocytosis, so above 10% of leukocytes, and with absolute monocyte count between 0.5 and 1 giga per liter. And they share a mutational profile with CMML patients, and roughly 1/3 of these patients evolved to genuine CMML over time. So next slide, please. At the same time, we and Eric Padron's group have described that, have demonstrated that roughly 1/3 of MDS patients display an accumulation of classical monocytes above 94% at diagnosis. And we demonstrated that around half of these patients evolved to a genuine CMML within 1 year. Next, please. And recently, we have confirmed these results. You can see the MDS CMML-like patient shown in green, who displayed higher percentage of monocytes in the peripheral blood and in the bone marrow. And these patients also exhibit the GM-CSF hypersensitivity, such as CMML patients. You can see here for low concentration of GM-CSF. And again, we confirm that these CMML-like MDS patients evolved to overt CMML over time. Next slide, please. And interestingly, this patient, this CMML-like patient, displayed multiple TET2 mutation, such as CMML patients. And this patient, when we stratified on the mutational profile, they were likely to evolve into CMML. And next slide, please. And this result were confirmed also by a recent study who demonstrated that oligomonocytic CMML patients displayed, for half of them, multiple TET2 mutations shown in dark blue here. And this patient also displayed an accumulation of classical monocytes. So I hope to have convinced you that flow cytometry and study of the monocyte, peripheral blood monocyte repartition is a real tool for diagnosis CMML and a subset of MDS patients that are likely to evolve to CMML. Do we have to call them CMML? That is the question. This patient from who displayed 0.5 to 1 giga per liter monocytosis. But I think they have to be really defined, and the clinician has to be informed of that diagnosis. And then I pass the talk on to Dorothée for the prognosis part.
Thank you, Oriane. Next slide, please. So our last point will concern the usefulness of the flow cytometry for as a prognosis tool for CMML. And there is 3 points, 3 studies that I want to highlight for you. The first point concerns a study in the bone marrow cells. A few years ago, long time ago, cytologists described some little island of CD123 positive cells in about 20% of the bone marrow sample patient. And with a flow cytometry, we were able to identify and these cells are as true plasmacytoid dendritic cells. And we quantified them, and we showed that in 20% of the CMML patients, this accumulation of PDC is associated to a worse prognosis and to an accumulation of Treg cells. Next slide, please. Concerning the peripheral blood cell study, as Oriane just showed you, the monocyte subset distribution is a good tool for the diagnosis of CMML, but can also be used as a prognosis factors, because in maybe 10 to 20% of the CMML cases, we observe this kind of profile with an accumulation of a classical monocyte, but also an accumulation of intermediate monocyte with the disappearance of the non-classical monocyte. Most of the time, this CMML patient associated with the CMML an inflammatory state, And we named them the flow cytometry defined inflammatory CMML. And as you can see, this kind of CMML patient have a bad prognosis compared to the CMML with the patient showing a classical profile of CMML for the monocyte subset distribution. We have now to study, to characterize better this inflammatory CMML to understand which kind exactly of inflammatory state is linked to this profile. And we now improve the panel and the study of the monocyte subset with the SLAN marker to better find this CMML patient. Next slide, please. And the third point concerns now the neutrophil population. As you can see here on this blood landscape obtained by spectral flow cytometry, there is a little population here that accumulates sometime in CMML patient blood. These cells are neutrophils, but immature neutrophils. And their quantification showed that they are not present in the control blood, but in some CMML blood samples. Next slide, please. In a large cohort of patients and control, we quantify by flow cytometry this immature neutrophil, and we observe an accumulation in red for this population in about 40 to 50% of the patient. And this accumulation is correlated with a bad prognosis concerning the event-free survival and the overall survival. Now it's a current work, and Christophe Wilkins will show you tomorrow how this, the presence of these cells can be linked with the physiopathology of the CMML. So next slide, please. So to conclude, using the flow cytometry in CMML can be an helpful tool for the prognosis and the diagnosis. In the bone marrow cells for the PDC identification and quantification as a prognosis marker, and in the peripheral blood cells to identify and quantify the monocyte subset as a diagnosis marker and as a prognosis marker. And I hope soon we will be able to present you how to quantify the mature granulocyte as a prognosis marker. Next slide, please. And with that, I want to thank all the people associated to these studies. Thank you.
So maybe we should sit here. He's there. Okay, so thank you very much for these insights. I mean, many people still think flow cytometry is a sophisticated thing which makes beautiful papers and also mechanistically shows a lot of things, but is it really needed if you have, and again, I'm challenging you, of course. So is it really needed if you have a crystal clear MDS, morphology clear, monocytes clear, blasts 7%, cytogenetics deletion 20q, everything is clear, molecular U2AF1, okay? So is it a nice to have thing also from a prognosis perspective? You said yes, no?
I think a clear cut is, do you need it in really clear-cut cases? Simple answer is no. However, if you then look to prognostic significance, or you are looking in monitoring under a specific drug exposure, it makes sense. Then you also can say, okay, if I have a del5q, for instance, make an easy example. Really, it was shown by several groups, also by your group, that if you monitor that on the lenalidomide, you get a restoration of normal hematopoiesis, which can also be seen by the flow. But in that case, you can also use del5q absence, so etc. But in the SF3B1 setting, for instance, you can really use these kind of studies to look into the restoration of, in this case, abnormal erythropoiesis. So the question is also, can you then direct clinical decision making thereafter? Otherwise, it's only a tool which have no implications. Then the answer is a little bit difficult. In the setting of del5q, I think no. In the setting of ASA treatment, in the traditional way of ASA, for instance, you can. We've shown is two papers show that if you are in the ASO after 6 months and you have stable disease and ask yourself, there's no progression, shall I continue or not? Then if you can add normalization of aberrant phenotypes, then the prognosis is much better. Then you can argue you have to continue. So there are a lot of things to be discussed, but not clear-cut yet.
So to make it very pragmatic, so you did a great job on CMML. So Dakota, you have seen the trial was a negative trial. So implementation of flow cytometry into the Dakota trial, maybe stratification, would that have prevented the outcome of the, I mean, when I say prevented, I mean, what could be the next trial from your perspective in CMML patients randomized within the group where flow cytometry will be a key stratification marker, inflammatory versus non, something like this, toxicity, neutropenia, thrombocytopenia. So suggestions. No, just talk and it will switch on.
Oh, okay. So I think for a CMML diagnosis, as you told, flow cytometry can help us to define the CMML inflammatory form. And I think also that that particular subset of MDS patients who displayed either just numerous features. I think that the definition of oligomonocytic CMML should not be used just with the monocytosis cutoff of 0.5 because we and others have demonstrated that MDS patient with lower level than 0.5 can display classical monocyte accumulation or and even multiple T2 mutations. So I think we have to focus on this particular population of MDS. And I think this patient should be perhaps not in TMML trial, but perhaps in MDS trials, just not treat, but I think they should be followed are the particular subset of MDS patients, just to see how they respond, how they evolve. But I don't know. You want to add something?
The first point concerning the Dakota trial, I look at the monocyte subset repartition for each patient at each 3 cycles of decitabine, for example, because the monocyte subset repartition can be used also for the answer to the treatment. We observe that we have the 3 monocyte subsets that reappear when the patient answers to the treatment. And most of the time, the patient that answer to the azacitidine showed these 3 populations, but after 6 months of treatment, they disappear again. So we have to discuss with Raphael to correlate this.
Then clinical decision making. So you said under HMA, whether it was ASA in the past or decitabine in the Dakota trial, you will see that after 3 cycles, there is a normalization of the partition, right? But then, what is then the clinical decision thereafter?
There is no link between the clinical decision and what I observed, but we have to correlate this. I answer to your question. Can we maybe anticipate some answer in the Dakota trial now? But maybe we can follow with the monocyte subset, maybe think about modified, I don't know, but it is an observation I made. And maybe we can look every 3 cycles, what are the answer, the clinical answer, and what was the monocyte subset repartition to see if there is a correlation.
If there is a normalization, you continue treatment. Are those patients which do not normalize the M score did worse? You don't know yet.
I mean, I would rather consider it from the toxicity perspective. So, you showed the subset of patients with auto-inflammatory monocytes.
Yeah.
So maybe those are the ones with more toxicity, and those are the ones with SAEs, and maybe those ones should be spared, just as a hypothesis, spared from clinical trials with HMA-based therapy, or should be supervised in a different fashion. I think this could also be. I'm looking to the PI. He's not looking at me, but anyway, maybe this could be an interesting analysis.
Actually, in the ASA trial we did before, we had the observation that those patients in the ASA that was high risk MDS were not CMML. If there is a normalization without hematological improvement, they do better. And then you are allowed to continue treatment despite the management of toxicity, for instance. Or you might allow more toxicity if the responding patients do better, if there is a flow cytometric normalization, either in CML, but that is not proven yet, but in some cases in MDS, you show that. It is shown. So then the toxicity question is, I think, a good way to think.
So my bottom line message with flow cytometry, I think, as you said before, it's a good, important tool to prove diagnostically that it's what kind of disease it is. But I think rather than doing more and more sophisticated research, which I think, of course, is mandatory, but I think flow cytometry should be integrated into, I mean, which you are doing this. I'm not against, I'm challenging you into a rather holistic platform to understand and to define a subgroup of patients where we can do small but very dedicated trials in very homogeneous patients. And because this all-comer strategy, high-risk MDS, ASA versus ASA plus is not going to work anymore. I mean, it definitely doesn't work in our cohort or in our platform. But also for industry purposes, I think this should be the rationale. Are you agreeing on that? Or?
I completely agree. It was my second point.
Yes, sorry.
No. But we have to be very careful.
Yeah.
Maybe flow cytometry is one tool, but we have to be careful when Raphael answered this evening about do we have to mix essay between CMML and MDS, and he said no, we have to be very careful to the diagnosis of CMML.
Exactly, and I think that's also important not to mix high-risk CMML with high-risk MDS trials, and I think their flow is also very important, to be a diagnostic qualifier. Raphael?
If I can jump in this conversation, the first thing is, I think, as you pointed to that, actually, I think we can leverage the Dakota data to identify, okay, so we have these response criteria and we know how they are designed. Like people sit around the table and say, well, what about? And using standard threshold, etc. So with the Dakota trial, with let's say, without a priori, we can identify very simple early on surrogates of, let's say, for instance, HMA's activity. So that's the first thing. We have an early surrogate endpoint. And then the second thing is, we don't even have to have any a priori knowledge of what is going to be the fancy flow cytometry marker. Lionel will smile because this is my enthusiasm of this period, but our statisticians are using Bayesian methods. That's the one. And these methods can be used for enrichment of biomarkers. So you start your trial without any flow-based eligibility criteria, but you capture dynamically over the trial the flow patterns of those patients. You have this early surrogate marker, and during the trial, you adaptively enrich those patients which you think are benefiting.
That should be the future of trials we are doing together.
Yeah.
Would you
May I
agree?
ask then, but I do not understand, if you look to the Dakota trial, the direct hydroxyurea versus decitabine, there was a negative study in the way that they are equal. Why continue then with decitabine in this respect? Or may I not ask that question? What is still the reason to continue with decitabine or HMA in higher risk proliferative CMML because of the trial outcome? Sorry for that critical question.
No, it's an excellent question. So you were on the tarmac or in the plane, but when I discussed the Dakota data, but this is yet unpresented. So we are currently, running some additional correlative studies in the Dakota trial, and maybe we can generate a signal that shorter exposure to decitabine can help us tease out the activity without getting too much of the cumulative toxicity in those patients. That is my hope.
So I think we still have this discussion pending on transplant approaches.
Is there room for one short question to Dorothy? No? Oh, yes?
Of course,
okay.
yeah.
And your last slide was very intriguing regarding the immature granulocytic compartment, which may identify a higher risk subset within CML. Are those myeloid-derived suppressor cells of the granulocytic lineage you identify? You did not mention that word, because maybe those cells do not exist, or what are these cells?
You are challenging me.
I'm challenging you here.
So I did this experiment, and the immature granulocyte we identified were considered as true PMN MDSC cells with immunosuppressive activity. I tested them. They are. No, I didn't mention it because a part of this work will be presented tomorrow by Christophe. She's there in the room, and maybe we'll go again on the discussion about what kind of CMML we can treat and which kind of treatment we can propose for CMML.
I will reserve the questions, other questions for tomorrow, because I had additional questions on that subject, but I will ask tomorrow then.
Sorry, I just learned that Marie is not joining, Marie Robin, right? Yeah, so she cannot make it. Good. Sorry, you want to? No, stay with us. It's very cozy, very nice. I like it. I like it. We still couple champagne. No, but I think we also had a little bit the concept of the and I think the final point is the transplant approaches, which I think we should cover in a couple of seconds, and then maybe close the session if the chair agrees. So David, maybe you can come here. I think it's common sense at this stage. Oh, let's ask our Dutch friends first. How are you, a patient with 14% bone marrow blasts at the age of 65 coming to your practice, having a del20Q and anemia thrombocytopenia? And the patient is fit, ECOG 0. How would you transplant this patient? Upfront allo? You said upfront allo, okay.
But that I say it so fast.
No, okay, so let's challenge you. Number one, what's the conditioning regimen in this patient?
Yes, that is exactly the question. In a fit 65-old patients, I would argue for myeloablative conditioning. If the same patient is less fit, you might argue a reduced intensity, although the outcome without myeloablation, without a induction scheme, is the discussion. So there is not a true answer. However, we have on a weekly basis the same discussion with transplanters without knowledge on, for instance, without knowledge of myeloid underlying diseases. And that's exactly, there is no trial yet. But to spare toxicity by conventional induction, you might argue to have a myeloablative regimen and upfront transplant.
Okay.
But now,
Wait a
David.
second. Now I challenge you further. You do a molecular workup and the patient has an IDH1 mutation on top of what I said. Deletion 20q, 14% bone marrow blast, pancytopenia. And you just came back from ASH where Marie Sebert
showed the EVO data,
presented the IVO mono data, and within the compassionate use program in your country, IVO is now available. So,
yeah,
what
that's
would you,
really
what
a challenge.
Would you do?
Then,
of course, this is
yeah,
a little bit.
So then the arguments are you then have a kind of an induction phase with IVO mono or IVO whatever, and then go to a transplant, and or then maybe not doing a myeloablative transplant. I think there's no answer.
Yeah.
But I still argue then, if the patient is fit, I do not believe only in a reduced intensity scheme by high tumor load.
Yeah.
But
no, I think there is no data for supporting this. Therefore, I think it's important to share.
But my point is that in the first question,
Marie is joining, but I will ask her the same question in 2 seconds.
Yeah, the question is, which is the probability of obtaining complete remission or indeed a good complete remission? In this case, with 20q minus almost normal karyotype, you have around 60% of probability of obtaining complete remission with 3+7. So if the patient is fit, probably I will try to obtain complete remission before transplant, especially if the patient doesn't have HLA sibling, HLA match sibling. If you are allowed to use ASA plus VEN, this will be also a good option with the same intention to obtain a deep response. Or even with the data we have with big cells in around 30 patients with MDS, I will also opt for this option. Of course, in the second part of the question with EVO and with the results we saw of monotherapy, of course, I will consider EVO, because the thing I think that is to obtain complete remission. If you have a complex karyotype, TP53 mutation or whatever, probably going to transplant is the best approach because you will not obtain this kind of response.
But the EVO data are beautiful. However, I haven't seen the data this afternoon in detail. However, you get not rid of the EVO clone in general. Does that matter or not?
No, you will reduce the blast count, and I don't know how deep the response can be in 1-2 cycles because of course the important thing is to get the transplant in 2-3 months before progression.
The difference between 2% of blast of 12% of blast.
Sorry?
Then the
14%.
14.
Yeah. No,
14
to 2.
to less than 5%.
That's the question. Is debulking, is this needed? I think there's no answer to this. And actually, according to ICC, a patient with 20Q and 14% blast is an MDS AML MR, because it's basically 20Q, I think, is part of this. So Marie Robin, we talked a lot about Marie. Marie, are you there?
I'm here, but I don't know if you can hear me.
Yes, we hear you pretty well. So tomorrow is Saturday, but on Monday you have outpatient service in your hospital, and a 65-year-old patient comes to you with 14% bone marrow blasts, clinically fit, severe anemia and thrombocytopenia, and a deletion 20q. What is your recommendation apart from including the patient into your trial? Outside the clinical trial, how would you transplant this patient?
I think that's not very different from the previous discussion because there is if we can transplant this patient, if she has a donor, and this donor is available, which is not always the case. So I would be in favor to transplant her upfront, and usually with a reduced intensity regimen because of the age. And I don't think we have many evidences to apply monotherapy by hypomethylating agents. Even the prospective trials we have now, we have this trial comparing 5-ASA to transplantation, but in this German trial, all patients receive a hypomethylating agent before transplantation, but the multivariate analysis that did not show an advantage in patients who were in complete remission. So we are even not sure, sorry to be provocative, but we are even not sure that a response is beneficial in these patients. And even it can be, of course, but that's a bias of selection. And does not mean that the non-responder should not be transplanted. So that's my answer.
You can be provocative because this meeting is full of provocation so far. So we are fine. So I will provocate, or I will challenge you as well. The same patient, same age, yeah, not 14% blast, but 21. What would be your? You would give AZA-ven then before transplant or induction, or what would you do? Or would you also do an upfront transplant?
So that's indeed the question of patients who probably have more an AML than MDS. And sometimes there is this gray zone where we don't really know. Of course, these patients has more molecular alteration in favor of MDS, as I understood. But due to the marroblast, honestly, we will do something before transplantation in these specific patients, because we will consider she had an AML.
Yeah. So in your trial, I mean, we learned today that in France, they are doing this trial with upfront, which I think is a good one, but it's not randomized, right? It's upfront transplant, not randomized. Your trial in France with the less than 15% blast?
Yes. That's a phase 2, a prospective phase 2, including all MDS patients, except those who are more than 15% blast, for exactly the reason I explained just before, because we don't want to transplant AML up front, but MDS up front. And we also included only patients who have a related donor, because we are not sure that selecting an unrelated donor will be feasible in terms of logistic. Usually we have 6 to 8 weeks to recruit an unrelated donor, so that's quite long, but that's life. So in this protocol, we will only have patients with haplo or HLA match sibling donor. But we've done this choice, and I think in Germany you have done another choice, but I don't have the answer. I just know that we are losing 20 to 30% of the patients between the beginning of the hypomethylating agent and the transplant. And with this protocol, we hope that we will have a high percentage of patients who will undergo the transplantation. I don't know, of course, if it will be better than yours. You may explain it, maybe.
But I think to answer your question, and then Thomas is actually has a point. Maybe at the end we can mix or combine our our study reports and maybe define subgroups of patients benefiting from the best approach, debulking, bridging versus upfront transplant. I think that's a kind of personalized approach. But Thomas, please. No, it works. Yeah.
Hello, Marie. Just a question for the clinical trial with the upfront allo in MDS. Do you think you need to standardize the maintenance post allo in this patient? And do you think for this patient we need systematically propose, I don't know, as a azacitidine in DLI or something else?
We haven't planned that in the protocol, except that we authorize preventive DLI. For me, I don't have enough evidences to systematically treat the patient after transplantation, because even if we have some retrospective studies of encouraging phase 2 study and so on, we don't have a randomized trial proving that it is beneficial. I think that that's different if we can detect the disease at a very low level, for instance, by molecular studies, or I don't know if flow cytometry can have a room for that. But anyway, if we can detect the disease, or if the chimerism is failing, in this case, that could be justified to start treatment early. But I won't recommend now prevention for everybody.
David, you want to say something?
I fully agree that we need to do a close follow-up of the disease after transplant, and in the case we detect disease by any method. Uwe showed many years ago the mischimerism, and the use of azacitidine, of course, is not proven to be efficacious in the phase 3, but to be honest, that trial was impossible to show any kind of benefit because the population was really, really very bad. So I think that we have enough evidence today to use azacitidine after transplant if you are detecting minimal residual disease and combining it with DLI, because otherwise azacitidine alone will not be enough. So I think that we need to incorporate this kind of actions after transplant. Of course, the best would be to perform a clinical trial, but if we are not being able to do that, at least with the data we have, I think that we are doing good if we include these actions after transplant.
So we have just finished the phase 2 protocol of oral decitabine from Aztecs in very high-risk patients, meaning that complex karyotype TP53 mutated patients. So I don't have the results, but I can see that again, we have some difficulty to start the treatment after transplantation. That's the main issue, because patients are not always fit enough, or in specific hematological recovery, so not able to receive this therapy in prevention. So that's always a challenge to treat this patient after transplantation. So we'll see what will be the result of this study. And indeed, ideally, a randomized study should be welcome, but difficult to set up. But there are this variety study, which is just ongoing, using Vidaza and vein after transplantation. Maybe we will have some kind of answer for this combination.
Is why in the stem cell community a randomized trial on the single great centers as you are, or on an EMSCO platform, or whatever the platform might be, Why is that not visible? We cannot get, I think your trial is okay, but why not randomizing upfront versus not upfront, maintenance or not? We can do in a multiple of clinical trials, we can, but in transplant, I'm transplanted, but not in the clinical groups who made trials, but.
This is for me or?
You want to answer? I mean, you can answer and then maybe I can say something.
Okay. So we have studies of randomizing maintenance after transplantation. That's what just I said before. We have this VLT study. So we're just waiting the end of this study. And there were two randomized trials comparing upfront to chemotherapy. But there were less than 5 patients included in these 2 trials. So at the end, they were stopped. So that's why we are a little bit reluctant to start again such a study, because we know that the community is convinced either for the chemo or hypomethylating agent, or it is convinced for upfront, but at the end we have difficulty to include the patients in the randomized trial.
I think the transplant community is a very specific mix out of people who have experience, gut feelings, emotions, networks, so it's really hard to bring them and to unify them and to bring them on one table, because as you pointed out, it's sometimes like cooking a soup for a patient. I give him a triosulfan at the 50% dose. I add cyclophosphamide. I give a DLI on day 56, and yeah.
Therefore,
so
we ramp up with evidence based on.
But I think that's because the allogeneic stem cell transplantation is the only approved cell-based therapy which was developed on an academic level. With different, not like CAR T cells. So this is pharmaceutical company driven, and I think therefore the history is that there are a lot of communities, believers, non-believers. I think that's also the reason. Number 2 is you always need money to run a trial, and you need to incentivize a pharmaceutical company to be part of this endeavor, and that's also the reason why we don't. And transplant trials are very expensive. Also, you need long-term follow-up.
As we now try within the whole from the Corbini study, as we showed too, which is paid by the government.
Yeah.
And this kind of establishing saving money by upfront or by a myeloablative or reduced intensity of whatever, you can calculate several ways. So that could also be a direction.
I think to consider an upfront trial for a patient with 14% blast, just to consider to perform, I think is a reflection of the limited opportunities we have to control the disease in this way. If we would have a magic bullet for P53, for IDH, for SRSF2, there would be no discussion. Is this a fair assessment? Thank you. Thank you. Okay, so I think that's a fair assessment in front of. So Marie, thank you very much. I hope you have a wonderful dinner tonight, because we have one. We have Italian food, but the rest actually will come from the chair. Thomas, please.
Okay, so bon appétit. Thank you so much.
The first day of the meeting. So we have a meeting diner at 8 p.m. So the name of the restaurant is the Boccaccio. It's close to the hotel, so you can go in walking or using the tramway. So I think you have the address here. So this is the Masséna Street. It's really close. So we will see at the restaurant at 8. See you later. Thank you.